You might think you have a pretty good handle on your stomach, that seemingly simple pouch where food goes for quick stop. But what if I told you it's actually a microscopic battleground, a highly sophisticated chemical lab of acids and enzymes, and even home to tiny, powerful bacteria that can completely transform its landscape?
Mm-hmm.
This intricate internal world can lead to some of the most challenging medical conditions we face, from relentless pain to, well, life-threatening emergencies.
Welcome to the deep dive. Our mission today is to take an incredibly comprehensive look at two powerhouse organs, the stomach and the duodenum. We're not just skimming the surface here.
Not at all.
We're drawing our insights from foundational medical texts, particularly Bailey and Love's Short Practice of Surgery, a true guiding star for surgeons and clinicians worldwide. Our goal is to go beyond mere understanding. We're aiming for mastery. We want you to grasp this topic with a kind of depth and interconnected insight that truly sets elite professionals apart.
That's right. Imagine having a top-tier medical expert walk you through these complex systems, pointing out every critical detail and connecting all the dots. That's what we're aiming for. We'll journey through the astonishingly intricate anatomy and physiology, uncover the surprising, even Nobel-winning impact of tiny organisms you've probably heard of,
Oh, yes.
but whose influence you might not fully appreciate. Then, we'll dissect common diseases, explore their cutting-edge treatments, and even venture into the latest in cancer pathology and management.
Prepare for those genuine aha moments. We're going to build a robust foundational blueprint of these organs, then delve into the critical importance of specific bacteria and inflammatory conditions. We'll unpack persistent challenges like peptic ulcer disease and brace ourselves for the acute crises these conditions can cause. And finally, we'll explore the broad, often nuanced spectrum of gastric and duodenal neoplasms.
Sounds like a plan.
By the end of this deep dive, you'll not just know the facts, you'll understand the why behind them, giving you a truly well-informed perspective.
All right, let's begin this deep dive, starting with the very foundational blueprint of these organs, the anatomy and physiology of the stomach and duodenum. We'll kick things off with their gross anatomy, essentially, the visible infrastructure beneath the surface.
Okay.
Now, we all know the stomach's primary role. It acts as a vital holding tank for ingested food. It's where the literal mechanical breakdown and chemical digestion really get going before its contents, now a partially digested slurry called chyme, flow onward into the duodenum. But the complexity behind that seemingly simple role is truly profound, a marvel of biological engineering.
What's truly fascinating here and critical for understanding any pathology is the sheer sophistication of the stomach's blood supply.
Right.
It's not just a few vessels. It's a rich and strategic network.
Right.
Think of it less like a single pipeline and more like a complex, multi-layered highway system designed to ensure constant, robust fuel delivery no matter what. This extensive collateral circulation is incredibly protective, and it's why the stomach can often withstand significant trauma or surgical manipulation.
Exactly. Let's trace some of these key highways. On the lesser curve, that's the shorter inner curve of the stomach, you have the left gastric artery, which branches directly off the coeliac axis, a major artery off the aorta supplying the upper abdominal organs. This left gastric artery then forms a crucial connection, an anastomotic arcade as we call it, with the right gastric artery, which comes off the common hepatic artery. Branches from the left gastric even extend upwards, providing blood to the cardia, the uppermost part of the stomach near the esophagus. This arcade acts like a vital bypass system, ensuring blood flow from two directions.
Then, if you shift your attention to the longer outer curve, the greater curve, you encounter another important connection.
Right.
Here, the right gastroepiploic artery, which is a branch of the gastroduodenal artery, itself originating from the hepatic artery, runs along the greater curvature and connects with the left gastroepiploic artery, a branch of the splenic artery. This elaborate vascular arcade on the greater curve is especially important during specific surgical procedures, such as esophageal resection. In these cases, this network is often used to create a gastric conduit, essentially, a new esophagus made from a portion of the stomach to reestablish digestive continuity. Its completeness, however, can vary from person to person, which surgeons must carefully assess.
And here's where this level of detail gets really clinically interesting, especially for you, the listener, in understanding emergency situations. The gastroduodenal artery we just mentioned, it passes directly behind the first part of the duodenum.
Right behind it.
This anatomical proximity is critically important because if a duodenal ulcer, an open sore in the lining, erodes deeply enough, it can breach this major artery. When that happens, it leads to potentially massive, life-threatening internal bleeding, which is a true surgical emergency. It's a classic high-stakes scenario.
Indeed. And for the very top, dome-shaped part of the stomach, the fundus, its blood supply comes from what are called the vasa brevia, or short gastric arteries. These originate from near the termination of the splenic artery.
Okay.
This highlights just how intricately interconnected the stomach's blood supply is, drawing from multiple major sources and underscoring its vital role in the body. It's a system designed for resilience.
Now, when it comes to venous drainage, how the blood leaves the stomach, the general principle is straightforward and beautifully efficient. The veins typically accompany their arterial counterparts.
Makes sense.
So the veins running along the lesser curve drain into the portal vein, which carries nutrient-rich blood to the liver, and those on the greater curve drain into the splenic vein.
But there's one vein on the lesser curve that merits particular attention. The coronary vein, sometimes called the left gastric vein. It runs along the lesser curve towards the esophagus and then courses to the right to join the portal vein. This vein becomes markedly dilated, or swollen, in a condition called portal hypertension, which is often caused by severe liver disease like cirrhosis. Its engorgement is a vital clinical sign that surgeons and gastroenterologists look for, as it can indicate serious underlying issues affecting blood flow through the liver.
Moving beyond blood flow, let's talk about the lymphatics, this silent but absolutely critical network. While we'll dive deeper into their specific role later when we discuss gastric cancer, it's important to acknowledge their profound significance in gastric cancer surgery right from the outset.
Absolutely.
Think of the lymphatics as the body's hidden pathways, a sophisticated drainage system that, while essential for immunity and waste removal, can also unfortunately serve as a primary route for disease, particularly cancer, to spread. Understanding these pathways is paramount.
And then we come to the nervous control, the sophisticated intrinsic and extrinsic orchestrators that direct the dynamic processes within the stomach and duodenum. Within the gut wall itself, there are two primary intrinsic plexuses, essentially mini-brains embedded in the digestive tract.
Like little command centers?
Exactly. First, the myenteric plexus, also known as Auerbach's plexus, primarily governs muscle activity, dictating the rhythmic contractions that move food along.
It's fascinating how their density isn't uniform. The myenteric plexus, for instance, has relatively few nerve cells in the fundus, the upper part of the stomach, but it's very well developed in the antrum, the lower part.
Right, which makes sense.
This difference makes sense when you consider the antrum's role in powerful grinding motions that mix and propel food. Similarly, the submucosal plexus, or Meissner's plexus, primarily controls secretion and local blood flow, and it also shows variable density, being less developed in the stomach compared to other parts of the gut. These subtle variations speak volumes about regional specialization.
For extrinsic control, we primarily look to the vagus nerves, known as cranial nerve X. These nerve fibers originate in the brainstem, in your head, and then condense into a plexus, a network, around the esophagus as they pass through the esophageal hiatus. That's the opening in the diaphragm. The posterior bundle is often identifiable as a large, distinct nerve trunk.
Okay, these fibers serve dual purposes. They're both afferent, carrying sensory information from the gut to the brain, and efferent, carrying commands from the brain to the gut. The efferent vagal fibers are incredibly busy, playing a central role in digestion. They're involved in what we call receptive relaxation of the stomach, allowing it to expand and comfortably act as a reservoir after a meal without increasing internal pressure.
Crucial function.
They also stimulate gastric motility, ensuring food is properly mixed and moved. And, of course, they have that well-known secretory function, particularly in driving gastric acid production. Historically, there was even a specific branch called the criminal nerve of Grassi, a small but clinically significant nerve related to the posterior vagus, whose incomplete sectioning during older vagotomy procedures could lead to recurrent ulcers. This specific detail highlights just how precise surgeons needed to be.
Right, it shows the history there. In contrast, the sympathetic supply, which often provides complementary neural regulation, is derived mainly from the coeliac ganglia, a cluster of nerves located near the coeliac axis. This system often has inhibitory effects, slowing down motility and secretion, providing a delicate balance with the vagal stimulation.
So that's our tour of the stomach's macroscopic visible structures. Now let's zoom in incredibly close and explore the microscopic anatomy, the cellular powerhouses that make all this astonishing functionality possible.
Let's do it.
At the very surface lining the stomach, you find surface epithelial cells. Their main job is to continuously produce a thick, protective layer of mucus. This mucus is absolutely crucial. It's the stomach's first line of defense, shielding its delicate lining from the incredibly harsh corrosive acid it produces. You also find similar mucus-secreting glands diligently working in the duodenum, ensuring protection there too.
But the real specialized action happens with dedicated gastric cells tucked deep within the gastric crypts, which are little invaginations in the stomach lining. First, let's talk about the parietal cells. These are predominantly located in the body of the stomach, which is the main acid-secreting portion. They effectively line the gastric crypts and become more abundant as you move further down towards the distal part of the stomach.
Their function truly is mind-blowing. These cells are single-handedly responsible for producing hydrogen ions, which then combine with chloride ions to form hydrochloric acid. And the ingenious mechanism behind this is the hydrogen-potassium ATPase proton pump.
The proton pump, yes.
This pump doesn't just move ions, it actively exchanges interluminal potassium for hydrogen ions against an immense concentration gradient. We're talking 1,000,000 to 1 concentration difference.
Incredible.
Imagine trying to push water uphill 1,000,000 times higher than its starting point. That's the powerful feat of cellular engineering happening constantly in your stomach.
What's incredibly clinically significant here is precisely how a class of drugs called proton pump inhibitors, or PPIs, work. These common medications, widely used to treat heartburn and ulcers, directly act by blocking this very H plus K plus ATPase pump.
Right at the source.
By doing so, they significantly reduce gastric acid secretion, effectively turning down the acid faucet. This understanding is a foundational piece of knowledge for treating a wide range of gastrointestinal conditions, from reflux to ulcers.
Then you have the chief cells. These are positioned a bit more proximally within the gastric crypts. Their job is to produce pepsinogen, which comes in two forms, I and II. Pepsinogen isn't active on its own. It requires the acidic environment of the stomach to be activated into pepsin, a powerful digestive protease that breaks down proteins.
And here's a subtle but important diagnostic indicator. The ratio of pepsinogen I:SiC in the serum, meaning in your blood, decreases when there's gastric atrophy, a thinning or wasting away of the stomach lining. This could be a quiet but crucial clue to underlying conditions affecting the stomach.
And let's absolutely not forget the endocrine cells. Think of these as a mini endocrine orchestra within the stomach and duodenum, each playing a crucial part in the digestive symphony, regulating everything with finely tuned hormonal signals.
A very apt analogy.
In the gastric antrum, the lower part of the stomach, you find G cells, which are responsible for producing gastrin. This hormone specifically stimulates acid secretion.
Throughout the body of the stomach, enterochromaffin-like, or ECL, cells are incredibly abundant. These cells produce histamine, which is a key factor in driving gastric acid secretion. It acts in a paracrine fashion, meaning it releases its signal to nearby cells rather than traveling through the general bloodstream.
Okay, local action.
Then you have D cells, numerous throughout the stomach, which produce somatostatin, playing a crucial negative regulatory role by inhibiting acid production.
And the duodenum continues this hormonal concert. It has its own set of endocrine cells that release vital messengers. For example, cholecystokinin stimulates the pancreas to produce digestive enzymes like trypsin and triggers gallbladder contraction, releasing bile.
Very important.
Secretin, another duodenal hormone, inhibits gastric acid secretion from the stomach and promotes bicarbonate production from the pancreas, helping to neutralize the acidic chyme as it enters the small intestine. It truly is a beautifully coordinated, multi-layered system.
Building on that intricate cellular and hormonal network, let's explore the physiology, the dynamic processes of digestion and regulation in action. The stomach's primary function, as we know, involves mechanical breakdown through churning and the chemical transformation of food into chyme using acid and pepsin.
What's immediately interesting is the contrast as that chyme, now highly acidic, flows into the duodenum. Unlike the stomach's acidic environment, the duodenum is designed to be alkaline. This neutralization is critical, and it happens thanks to a robust secretion of bicarbonate from both the pancreas, which ducts into the duodenum, and the duodenum itself.
Right, that alkaline bath.
This rapid neutralization of acid not only protects the delicate duodenal lining, but also fine-tunes the chyme's osmolarity, its concentration, to be roughly equivalent to that of blood plasma. This creates a much more hospitable environment for the downstream digestive enzymes to do their work.
Now let's dive even deeper into the intricacies of gastric acid secretion, which is a central and tightly regulated process. While many factors influence acid production, the central role of histamine, acting via a specific type of receptor called the H2 receptor on the parietal cells, is absolutely paramount.
Okay.
Remember, histamine is produced by those ECL cells we just discussed, and it acts in a paracrine, or local fashion, essentially shouting its instructions to nearby parietal cells.
This crucial detail explains a foundational difference in how various medications work. Proton pump inhibitors, or PPIs, can virtually abolish acid secretion because they directly block that final common pathway, the actual hydrogen ion secretion pump.
It's the final step, yeah.
H2 receptor antagonists, on the other hand, like ranitidine or famotidine, only profoundly reduce acid production because they block just one of the signals to the pump, not the pump itself. It's a subtle but profoundly significant distinction in their therapeutic efficacy.
The ECL cells, those histamine producers, are themselves stimulated by two key signals: the vagus nerve, which carries signals from your brain, and gastrin. Gastrin, as we mentioned earlier, is released by G cells in the antrum in response to the presence of food, particularly proteins. This system operates on a finely tuned negative feedback loop. As the stomach becomes more acidic, gastrin production is naturally inhibited, preventing excessive acid secretion.
And there are other important inhibitory peptides that act as crucial brakes on this system. Hormones like secretin and somatostatin play significant roles. Somatostatin, for example, is released by D cells in response to acidification. It acts as a triple threat inhibitor, directly inhibiting the G cells from releasing gastrin, the ECL cells from releasing histamine, and even the parietal cells from producing acid. It's like a sophisticated internal governor ensuring balance in this powerful digestive process.
Gastric secretion doesn't just happen randomly. It occurs in classically described phases, a beautifully coordinated response to eating. The first is the cephalic phase, which is mediated by vagal activity signals from your brain.
Even before you eat.
Exactly. This happens even before food enters your stomach, secondary to sensory arousal. Think of Pavlov's classic experiments. The mere thought, smell, sight, or even taste of food can trigger gastric secretions. Your brain is already preparing the stomach for its incoming meal.
Then comes the gastric phase, which is the direct response to the actual presence of food within the stomach. This phase is primarily mediated by the hormone gastrin, which gets the acid pumps really firing. And finally, the intestinal phase. As the partially digested chyme begins to enter the duodenum and small bowel, it triggers signals that actually inhibit gastric emptying from the stomach and further gastric acid secretion. For instance, duodenal acidification leads to the production of secretin, which again acts as a brake on stomach activity. It's a remarkable, coordinated symphony from start to finish.
Crucial to all of this, and perhaps one of the most vital components of the stomach's resilience, is the gastric mucus and the mucosal barrier, essentially the body's essential defense line.
That slimy layer.
It is, but it's not just simple slime. It's a viscid, gel-like layer of mucopolysaccharides, complex sugar-protein molecules produced continuously by the mucus-producing cells and pyloric glands. It acts as an essential physiological barrier, providing robust protection for the underlying gastric mucosa from mechanical damage, but more importantly, from the corrosive effects of its own acid and pepsin.
And it buffers too.
It does. It even has a considerable buffering capacity, enhanced by bicarbonate ions trapped within the mucus layer, creating a neutral zone right at the surface of the stomach lining.
But this barrier, as robust as it is, isn't invincible. Many factors can unfortunately compromise it, weakening the stomach's defenses. These include things like bile refluxing back into the stomach, the common use of non-steroidal anti-inflammatory drugs or NSAIDs, excessive alcohol consumption, and even severe trauma or shock.
Yes, all those insults.
What's particularly telling about its vulnerability is its extreme sensitivity to ischemia. That's when blood flow is reduced. Tonometry studies, which measure tissue oxygenation, have shown that, among all parts of the gastrointestinal tract, the stomach is the most sensitive to ischemia after a hypovolemic insult like severe blood loss or shock, and it's also remarkably slow to recover.
Okay, explains.
This crucial insight explains the high incidence of what we call stress ulceration, which is frequently seen in critically ill patients.
When we talk about communication within the gut, the role of peptides and neuropeptides is increasingly understood to be part of an incredibly complex and overlapping system. There's a growing realization that many messengers previously thought of solely as hormones can also be produced by neurons, blurring the lines between the nervous and endocrine systems, hence the term neuropeptides.
This means these chemical messengers can act in three main conventional modes. They can be endocrine, secreted into the bloodstream to affect remote tissues throughout the body.
The classic hormone route.
They can be paracrine, produced locally to exert effects on nearby cells, like our histamine example. Or they can be neurocrine, acting as classical neurotransmitters, diffusing across a tiny synaptic cleft to directly influence a target cell.
So very versatile.
This sophisticated system allows these messengers to act on the intrinsic nerve plexus within the gut wall, profoundly influencing both motility and the very structure and function of the mucosa itself. It's a truly remarkable internal communication network.
Finally, let's consider gastroduodenal motor activity, the rhythmic, coordinated movement that churns food and propels it along the digestive tract. A critical part of this is the migrating motor complex, or MMC.
The gut's housekeeper.
That's a great way to put it. This is fascinating because it only happens when you're in a fasting state after food has been cleared from your stomach and small intestine. It's a regular, recurring cycle, roughly every 90 minutes, designed to sweep the gut clean.
Yes, this 90-minute cycle has distinct phases. Phase on is about 40 minutes of relative quiescence, basically. The gut is mostly quiet. Then phase 2 kicks in, bringing about 40 minutes of increasing electrical and motor activity, with waves propagating from the fundus of the stomach at about 3 waves per minute, gradually extending all the way to the pylorus.
Ramping up.
And finally, phase 3 is a shorter, more intense period, about 10 minutes, where the amplitude of these contractions reaches a maximum. This powerful wave then propagates distally, moving down the duodenum at about 5-10 centimeters per minute, reaching the terminal ileum in about 1.5 hours, effectively sweeping any residual debris or bacteria into the large intestine. It's the gut's self-cleaning mechanism.
After a meal, this elegant fasting pattern shifts dramatically. The stomach exhibits what we call receptive relaxation, which is the ability of the proximal stomach to relax and expand significantly without increasing pressure, allowing it to act as a large, compliant reservoir for incoming food.
Like a balloon expanding.
Exactly. Most of the powerful peristaltic activity, often called the antral mill, because it's like a grinding stone, occurs in the distal stomach, vigorously mixing and breaking down food, while the proximal stomach maintains more tonic, sustained activity to maintain pressure on the food.
And the pylorus, the gatekeeper between the stomach and duodenum, plays a crucial role. While it's most commonly open, it contracts with each powerful peristaltic wave, allowing only a few milliliters of chyme to pass into the duodenum at a time.
Just a little bit at a time.
This deliberate antral contraction against a temporarily closed pylorus is absolutely key for that milling activity, ensuring food is ground down into a fine, uniform consistency before being released. It's this crucial and highly coordinated interaction between the antrum, pylorus, and duodenum that ensures only small, manageable quantities of food reach the small bowel at any given time, preventing overload and allowing for efficient digestion.
However, this exquisitely controlled gastric emptying can unfortunately be abolished or severely disrupted after certain types of gastric surgery. When that happens, it can lead to significant and often debilitating symptoms for patients, which we'll discuss in detail later.
Right, those post-surgery issues.
It's a testament to just how intricate and balanced this system is, and how surgical intervention, while sometimes necessary, can inadvertently disrupt fundamental physiological processes.
So we've laid the foundational groundwork, understanding the stomach and duodenum from their broad structure down to their cellular powerhouses and intricate regulatory systems. Now, let's transition to a truly game-changing discovery in gastroenterology: the critical importance of Helicobacter pylori and the inflammatory condition it causes, gastritis.
Ah, yes, H. pylori.
You've probably heard of H. pylori, but its story, culminating in a Nobel Prize, truly transformed our understanding of gastrointestinal health.
Indeed. While a scientist named Bizzozero had actually identified spirochaetal organisms in gastric mucosa much earlier, back in 1893, it wasn't until the early 1980s that two Australian researchers, Barry Marshall and Robin Warren, performed their pivotal work.
The Nobel winners.
They conclusively confirmed Koch's postulates for H. pylori and its causal link to gastritis and peptic ulcers. Their groundbreaking efforts, initially met with skepticism, rightly earned them the Nobel Prize in Medicine or Physiology in 2005, revolutionizing how we treat stomach ailments.
Their discovery truly changed everything. One of those unique characteristics and mechanisms of H. pylori is its remarkable urease activity. This bacterium possesses an enzyme called urease, which allows it to hydrolyze or break down urea, a common compound in the stomach, into ammonia.
Clever survival trick.
Ammonia is a strong alkali, a base, and this ammonia has a direct and significant impact on the antral G cells, causing them to release gastrin. This leads to what's called modest but inappropriate hypergastrinemia, essentially. Too much gastrin for the stomach's needs, which in turn can drive gastric acid hypersecretion, meaning the stomach produces too much acid.
This clever urease activity isn't just a pathological mechanism. It's also precisely how we diagnose H. pylori infection. Its obligate urease activity is utilized in various diagnostic tests.
Like the breath test.
Exactly. For instance, the 13C and 14C breath tests work by having the patient ingest a labeled urea solution. If H. pylori is present, it breaks down the urea, releasing labeled carbon dioxide that can be detected in the breath. There's also the CLO test, or rapid urease test, which is performed directly on gastric biopsies taken during an endoscopy.
Okay.
Beyond these, the organism can be detected histologically by examining tissue samples under a microscope, using specific stains like Giemsa or Ethan Starry's silver stains. While challenging, H. pylori can also be cultured from gastric biopsies. And finally, serology, a blood test, can detect antibodies to the bacterium, indicating a past or present infection.
Current recommendations for diagnosis wisely differentiate between community-based and hospital-based methods. For community settings where endoscopy might not be immediately available, breath tests or fecal antigen tests, which detect bacterial proteins in stool, are recommended for initial diagnosis.
Makes sense for primary care.
Less accurate, but still valuable, hospital-based serology tests can also play a role within a non-invasive test and treat strategy, especially in certain clinical situations.
Furthermore, H. pylori doesn't just produce ammonia. It also generates various enzymes and directly incites an inflammatory response that collectively disrupt the stomach's protective mucus barrier. Some strains of H. pylori are particularly aggressive because they produce cytotoxins, most notably proteins like CAG-A and FAC-A.
Those sound nasty.
They are. The presence of these specific cytotoxins is strongly associated with a greater ability to cause not only severe gastritis and peptic ulceration, but also critically an increased risk of gastric cancer. The bacterium incites a classical inflammatory response in the gastric lining, involving both acute inflammatory cells like neutrophils, the body's rapid responders, and chronic inflammatory cells like macrophages and lymphocytes, which sustain the long-term immune reaction.
And here's where the duodenal ulcer conundrum was brilliantly solved by the concept of metaplasia. For a long time, it was a real puzzle. Why would H. pylori cause duodenal ulcers when the normal duodenum isn't actually colonized by the bacteria? It seemed counterintuitive.
The elegant solution lies in duodenal gastric metaplasia. This phenomenon occurs when the duodenal mucosa, in response to chronic excess acidity from the stomach, undergoes a transformation. It essentially changes its cell type, taking on characteristics that resemble gastric or stomach mucosa.
It tries to adapt.
Exactly. You can analogize it to other metaplasias found elsewhere in the GI tract, like in Barrett's esophagus. It's the mucosa's adaptive attempt to resist injury by transforming into a type of cell better equipped to handle the harsh acidic environment. Here's the key. While normal duodenal mucosa resists H. pylori, this transformed gastric-like metaplastic tissue can be infected by the bacterium.
Ah, so that's the link.
Precisely. This infection then leads to duodenitis inflammation of the duodenum, which is almost certainly the direct precursor of duodenal ulceration. Once the H. pylori infection is eradicated, the acid levels decrease, the metaplasia often resolves, and the duodenal lining returns to its normal, resilient state.
The epidemiology of H. pylori infection is truly striking and reveals its global reach. It's potentially the most common human infection worldwide, with prevalence rates reaching up to 50% globally. And in some populations, particularly in developing nations, it can be as high as 80–90%, with incidence generally increasing with age.
Staggering numbers.
Most infections are acquired in childhood, and there's a clear inverse relationship with socioeconomic group, meaning it's more prevalent in areas with lower socioeconomic status.
While the exact means of spread aren't fully identified, leading to some ongoing research, fecal-oral transmission seems the most likely route, perhaps through contaminated food or water, as the organism's not normally found in saliva or dental plaque. What's also fascinating is how its manifestations vary regionally across the globe. For example, in the West, H. pylori predominantly causes antral gastritis, affecting the lower part of the stomach, which often results in increased acid production and a predisposition to peptic ulcer disease.
Right, the ulcer connection.
In contrast, in the developing world, gastritis affecting the body of the stomach is more common and may paradoxically lead to hypochlorhydria, reduced acid production, and an increased risk of gastric neoplasia, including cancer. This highlights a profound environmental influence on how the infection manifests.
When it comes to treatment and eradication, it's been known since as early as 1984 that Helicobacter infection responds to simple antibiotic therapy. Today's modern regimens typically combine proton pump inhibitors, which significantly reduce acid, with a cocktail of antibiotics, commonly including metronidazole, amoxicillin, or clarithromycin.
The standard triple therapy.
These combinations are incredibly effective, achieving very high eradication rates, often in the region of 90%.
The challenge for the future, of course, is the growing concern of antibiotic resistance, as with many bacterial infections. While true reinfection following successful eradication in adults is quite rare, generally less than 0.5% per year, incomplete eradication remains a more significant clinical problem.
Right, if it doesn't get fully cleared.
This often stems from issues like poor compliance with the full course of treatment or, as mentioned, bacterial resistance to the prescribed antibiotics. In cases of persistent infection, obtaining a bacteriological culture of the H. pylori strain can be invaluable, as it allows clinicians to test for specific antibiotic resistances and guide further, more targeted eradication attempts.
Currently, eradication therapy is unequivocally recommended for all patients diagnosed with peptic ulcer disease, as it addresses the root cause for most cases. It's not routinely recommended for non-ulcer dyspepsia, which is indigestion without a clear ulcer, or for asymptomatic infected patients. Although it's worth noting that recent data does indicate a proportion of patients with non-ulcer dyspepsia experience symptomatic relief after H. pylori eradication, suggesting it might have a role in a subset of these cases in the future.
And here's a crucial piece of information that underscores the long-term impact of this tiny bacterium. H. pylori is now classified by the World Health Organization as a Class 1 carcinogen.
Wow, class 1, like smoking.
Exactly. This means it's definitively recognized as a cancer-causing agent, similar to smoking or asbestos, specifically linked to gastric cancer. This classification has significant implications, strongly suggesting that future epidemiological studies on gastric cancer risk may very well lead to a broader recommendation for H. pylori eradication in wider populations, potentially as a preventative measure. It's a compelling example of how a microscopic discovery can have macro-level public health implications.
Moving on from H. pylori itself, let's talk about gastritis, which is simply defined as inflammation of the gastric mucosa or the stomach lining. Historically, medical classification systems for gastritis caused a lot of confusion, a tangle of descriptive terms.
Oh, they are a mess.
But thankfully, the clear understanding of H. pylori's role brought broad agreement on a classification system based more on the underlying cause. So when we say gastritis, we're talking about histologically confirmed inflammation, meaning it's visible under a microscope in a tissue sample.
One distinct and important type is autoimmune gastritis. This is an autoimmune condition, meaning your body's own immune system mistakenly attacks its healthy cells. In this case, there are circulating antibodies in the blood that target the parietal cells in the stomach.
The acid producers again.
Precisely. Over time, this attack leads to atrophy, or a thinning and wasting away of the parietal cell mass, which results in hypochlorhydria, reduced stomach acid, and ultimately, if severe enough, achlorhydria, meaning a complete absence of hydrochloric acid.
And because intrinsic factor, a protein absolutely vital for the absorption of vitamin B12 from your diet, is also produced by these same parietal cells, its loss due to autoimmune destruction causes B12 malabsorption. If left undiagnosed and untreated, this can lead to pernicious anemia, a serious blood disorder.
What's also unique and clinically significant about autoimmune gastritis is that the antrum, the lower part of the stomach, is typically not affected by this autoimmune attack. This lack of acid in the body of the stomach then leads to a compensatory effect. The G cells in the unaffected antrum start producing very high levels of gastrin.
Trying to boost acid.
Right. This causes chronic hypergastrinemia, persistently elevated gastrin in the blood. Over time, this chronic stimulation can result in enterochromaffin-like ECL cell hypertrophy in the body of the stomach, meaning these cells grow in number and, albeit rarely, can even lead to the development of microadenomas, small benign growths which rarely can become malignant. For these reasons, regular endoscopic screening and surveillance of such patients may be appropriate to monitor for any malignant potential.
Then we have Helicobacter pylori gastritis, previously known as type B gastritis, which, as we discussed, is caused by the H. pylori bacterium. This form of gastritis primarily affects the antrum, the lower part of the stomach, and significantly predisposes individuals to peptic ulcer disease.
Hmm.
While antral gastritis is common, it's worth noting that Helicobacter-associated pangastritis, where the inflammation affects the entire stomach, is also quite common. However, gastritis affecting only the body of the stomach without antral involvement is rare for H. pylori.
Chronic pangastritis, especially when it leads to atrophy of the stomach lining, is particularly concerning because it's strongly associated with intestinal metaplasia, another cellular transformation where the stomach lining begins to resemble intestinal tissue.
Precancerous changes.
Potentially, yes. When this metaplasia is coupled with dysplasia abnormal cell development, it carries significant malignant potential, increasing the risk of gastric cancer. Therefore, just like in autoimmune gastritis, endoscopic screening with biopsies may be highly appropriate in these cases to monitor for progression and catch any early signs of malignancy.
Next up is reflux gastritis, which, as the name suggests, is caused by enterogastric reflux. This is where bile and other duodenal contents flow backward or reflux from the duodenum into the stomach. It has distinct histological features that pathologists can identify.
You can see the bile damage.
While it's commonly seen after certain gastric surgeries that disrupt the normal flow, surprisingly, it can also be found in patients without any prior surgical intervention or even after a cholecystectomy, the removal of the gallbladder.
Treatment for reflux gastritis can be challenging. It often involves medications like bile chelating agents, which bind to bile in the gut, or prokinetic agents, which help speed up gastric emptying. However, these are often only partially effective. Revisional surgery, which means another operation to correct the underlying anatomical problem, is typically reserved only for the most severe, intractable cases, where symptoms are debilitating and medical management has failed.
Erosive gastritis, on the other hand, is caused by agents that directly damage and disturb the gastric mucosal barrier, creating superficial erosions, not full ulcers. Non-steroidal anti-inflammatory drugs, or NSAIDs like ibuprofen and excessive alcohol consumption, are common culprits.
The usual suspects.
The NSAID-induced lesion is particularly well understood. It relates to the inhibition of cyclooxygenase type 1, or COX1, an enzyme crucial for producing cytoprotective prostaglandins. These prostaglandins are vital for maintaining the stomach's protective mucus layer and blood flow. This is precisely why PHOX2 inhibitors were developed. They target inflammation while theoretically reducing the incidence of gastritis and ulceration by sparing the COX1 pathway.
Stress gastritis is a very common sequela or consequence of serious illness or injury. It's seen frequently in critically ill patients, those with major burns, severe trauma, or undergoing major surgery, and it's characterized by a reduction in blood supply to the gastric mucosa.
So reduced perfusion.
Exactly. Though it's common, it's usually not recognized until stress ulceration and bleeding suddenly occur, often with significant clinical impact. Prevention, typically using routine H2 antagonists or protective barrier agents like sucralfate in intensive care patients, is much easier and far more effective than trying to treat the severe bleeding once it has started.
Menetrier's disease is a truly rare and unusual condition characterized by gross hypertrophy, an enormous thickening of the gastric mucosal folds, giving the stomach lining a cobblestone appearance. It's also associated with excessive mucus production and, paradoxically, hypochlorhydria or low stomach acid.
Quite a strange picture.
It's considered premalignant, meaning it carries a risk of developing into cancer over time and may present with hypoproteinemia, a low protein level in the blood due to protein loss through the abnormal stomach lining, and anemia.
What's fascinating about Menetrier's disease is its proposed molecular mechanism, an overexpression of transforming growth factor alpha, or TGFO, a protein that binds to the epidermal growth factor, or EGF receptor. This specific molecular pathway has even been successfully reproduced in transgenic mice, providing a powerful model for research. Unfortunately, for severe debilitating cases that don't respond to medical management, the only definitive treatment for Menetrier's is a total gastrectomy, the surgical removal of the entire stomach.
Lymphocytic gastritis is another rare form of gastritis, characterized by a distinct pattern of T-cell infiltration, a specific type of white blood cell within the gastric mucosa. It's widely believed to be associated with H. pylori infection, suggesting an immune response to the bacterium.
Interesting link there.
Interestingly, its inflammatory pattern remarkably resembles that seen in other autoimmune-like conditions such as celiac disease or lymphocytic colitis, hinting at shared underlying immunological mechanisms.
And finally, a quick mention of some other less common forms of gastritis. These include eosinophilic gastritis, which is thought to have an allergic basis and is often treated with steroids. Granulomatous gastritis, which can be seen in systemic conditions like Crohn's disease or infections like tuberculosis. AIDS gastritis, often secondary to opportunistic infections like cryptosporidiosis in immunocompromised patients. And plegmonous gastritis, a very rare and severe bacterial infection of the stomach wall, often an agonal event, meaning it occurs in the final stages of a severely ill patient's life. Each represents a distinct pathology affecting the stomach lining.
So we've thoroughly covered the foundational anatomy and physiology, and then explored the various inflammatory conditions, including the monumental impact of H. pylori. Now let's get into section 3. Peptic ulcer disease, understanding this historically persistent, yet now largely manageable challenge.
Okay, ulcers.
The core principle of peptic ulcer formation is often summarized by the old adage, no acid, no ulcer. This is profoundly true. Nearly all benign peptic ulcers will heal with proton pump inhibitors, which can effectively render a patient achlorhydric, meaning the stomach produces virtually no hydrochloric acid.
Common sites for peptic ulcers are the first part of the duodenum, just after the stomach, and the lesser curve of the stomach, that inner, shorter curve. However, they can also occur in less common locations, such as on the stoma, the surgically created opening after gastric surgery, or in the esophagus, often in cases of severe reflux.
Even in a Meckel's diverticulum.
Yes, interestingly, they can even be found in a Meckel's diverticulum, a small pouch in the small intestine, if it happens to contain ectopic gastric epithelium stomach-like lining that produces acid. Generally, these ulcers tend to form at junctions of different types of epithelia, specifically in the epithelium that is least resistant to acid damage.
It's important to understand there's a spectrum of disease, from superficial ulcerations, which are essentially erosions that don't fully penetrate the muscle layer and are often seen at endoscopy, to deep, chronic, penetrating ulcers that can go through the entire stomach or duodenal wall.
Right, a whole range.
This spectrum also includes the critical importance of acute stress ulceration, which can suddenly develop in critically ill patients and lead to severe complications like perforation or bleeding.
For many years, the precise cause of peptic ulceration remained an enigma, a medical mystery. While it's true that patients with duodenal and prepyloric ulcers often have higher acid levels compared to the general population, the overlap with normal individuals is considerable, making high acid alone insufficient to explain all cases.
So it's not just about acid levels.
Not entirely. And patients with gastric ulcers often have relatively normal or even low acid secretion. However, the consistent thread is clear. Acid is important, as ulcers are unequivocally associated with very high acid levels, as seen in rare conditions like Zollinger-Ellison syndrome, and they consistently heal when acid is suppressed.
Today, the mystery is largely solved. It's now widely accepted that infection with H. pylori and the prolonged use of nonsteroidal anti-inflammatory drugs, or NSAIDs, are by far the most important factors driving peptic ulcer disease.
The big two.
Beyond these, cigarette smoking also significantly predisposes individuals to developing peptic ulcers and critically increases the relapse rate after successful treatment, emphasizing the importance of smoking cessation in managing this condition.
Let's focus specifically on duodenal ulceration first, as its epidemiology has seen significant shifts. There have been marked demographic changes in the West, largely due to the widespread use of potent gastric anti-secretory agents and, crucially, the successful implementation of H. pylori eradication therapy.
So, fewer cases now.
Fewer new cases, yes. The peak incidence for new cases is now seen in an older age group, and while still slightly more common in men, the gender difference has become less pronounced. These shifts directly mirror the changes observed in H. pylori epidemiology. However, it's a different story in Eastern Europe, where the disease remains prevalent and its incidence is actually rising in many resource-poor nations, highlighting the ongoing global disparity in its burden.
Pathologically, most duodenal ulcers occur in the first part of the duodenum, an area often referred to as the duodenal cap. A chronic ulcer doesn't just scratch the surface, it penetrates the mucosa and often extends deep into the muscle coat, leading to significant fibrosis or scarring.
That scarring can cause problems.
Exactly. This scarring can, over time, cause a deformity or narrowing of the duodenal outlet, a condition known as pyloric stenosis, which obstructs food flow. When an ulcer eventually heals, it typically leaves a residual scar. Interestingly, surgeons sometimes encounter what are known as kissing ulcers, where two ulcers, usually a posterior and an anterior one, coexist on opposite walls of the duodenum.
Clinically, there's a crucial distinction between anterior and posterior duodenal ulcers that surgeons pay close attention to. Anterior ulcers, located on the front wall of the duodenum, tend to perforate, meaning they can create a hole, leading to a surgical emergency as gastric contents spill into the abdominal cavity.
A major crisis.
In contrast, posterior duodenal ulcers, located on the back wall, tend to bleed severely, often by eroding into the gastroduodenal artery, that major vessel we discussed earlier, leading to potentially life-threatening hemorrhage. Occasionally, ulceration can be so extensive that the entire duodenal cap is involved, appearing as a giant duodenal ulcer.
Oh,
But reassuringly, malignancy in the duodenal cap region is so exceedingly uncommon that surgeons can generally be confident they are dealing with benign disease, even in cases of severe ulceration, which helps guide their treatment strategy.
now let's turn our attention to gastric ulcers. These are less common than duodenal ulcers, with an equal incidence between genders and typically affecting older patients. They also tend to be more prevalent in low socioeconomic groups and in resource-poor countries, similar to certain patterns of H. pylori infection. Like duodenal ulcers, gastric ulcers are strongly associated with H. pylori infection, the use of NSAIDs, and cigarette smoking.
Pathologically, gastric ulcers share some similar features with duodenal ulcers, but often tend to be larger and more irregular in shape. The fibrosis resulting from chronic inflammation can, in severe cases, lead to an hourglass deformity of the stomach, where the middle portion significantly narrows.
Wow, an hourglass stomach.
Chronic gastric ulcers can also erode posteriorly, penetrating into adjacent organs like the pancreas, or into major blood vessels like the splenic artery, causing severe bleeding. More rarely, they can even erode into other organs, such as the transverse colon. Gastric ulcers are most commonly found on the lesser curve, especially at a specific anatomical point called the incisura angularis. This location is often at the boundary between the acid-secreting part of the stomach and the non-acid-secreting epithelium, which shifts due to chronic inflammation and atrophy.
And here's the absolutely crucial malignancy link that sets gastric ulcers apart and demands extreme vigilance. Unlike chronic duodenal ulcers, gastric ulcers are strongly associated with malignancy.
This is T.
It is absolutely vital for clinicians to distinguish between the rare malignant transformation of a long-standing benign ulcer, meaning a benign ulcer slowly becoming cancerous, and the much more common scenario, which is an already ulcerated cancer simply presenting as a benign-looking ulcer. This distinction drives a fundamental diagnostic approach.
This leads to the golden rule in managing gastric ulcers. All gastric ulcers must be regarded as malignant until proven otherwise, regardless of how benign they may appear endoscopically or radiologically.
Assume the worst until proven otherwise.
Exactly. This demands meticulous diagnostic diligence. When a gastric ulcer is identified, it's not enough to take just 1 or 2 biopsies. Multiple, well-targeted biopsies, sometimes as many as 10 from the edges and base of the ulcer, are absolutely required to search for cancerous cells. Furthermore, because ulcers can appear to heal over a cancer, further biopsies are also needed during the healing process and, critically, once the ulcer has completely healed, to ensure there's no underlying malignancy lurking beneath.
Why this extraordinary caution? Modern anti-secretory agents, like PPIs, are so effective at suppressing acid that they can often heal the superficial ulceration associated with a gastric cancer, making it look like a benign ulcer has responded to treatment.
Deceptive healing.
However, these medications are completely ineffective against the malignancy itself. This creates a deceptive healing that can tragically mask the underlying danger, delaying a life-saving cancer diagnosis.
Furthermore, even experienced surgeons can struggle to distinguish a truly benign ulcer from a malignant one just by looking at it or feeling it during an operation. This is why a confident preoperative diagnosis based on thorough biopsies is absolutely essential before proceeding with any definitive surgical intervention.
Need that confirmation first.
For perforated gastric ulcers, where a hole has formed, excision of the ulcer itself and immediate histological examination of the tissue are mandatory to rule out malignancy, as these can also be the first presentation of a gastric cancer.
Beyond the common duodenal and gastric ulcers, there are a few other types of peptic ulcers worth noting. Pre-pyloric gastric ulcers, located just before the pylorus, were historically quite difficult to treat. However, with the advent of potent PPIs, their management has largely been resolved. But, like other gastric ulcers, malignancy is a concern in this area, so a thorough biopsy is essential to confirm their benign nature.
Same rule applies?
Similarly, pyloric channel ulcers, found within the narrow pyloric canal, behave much like duodenal ulcers, but again, malignancy must be meticulously excluded with biopsy.
Then there are stromal ulcers, which occur after certain gastric surgeries, specifically where a gastroenterostomy has been performed. This is now most commonly seen after bariatric surgery procedures that create a bypass, or after an older operation called a Billroth II gastrectomy. These ulcers are typically found on the jejunal side of the stoma, at the junction of the jejunal and gastric mucosa, an area particularly vulnerable to acid.
When it comes to the clinical features of peptic ulcers, it's important to emphasize a key point. Gastric and duodenal ulceration often cannot be reliably differentiated based on symptoms alone.
The symptoms overlap a lot.
While the demographic characteristics of the patient groups might differ, for example, duodenal ulcers sometimes affecting younger males, gastric ulcers more older individuals, the pain and other symptoms can be remarkably similar.
The hallmark symptom is epigastric pain. Pain in the upper central abdomen, often described as gnawing, burning, or aching, and sometimes radiating through to the back. For duodenal ulcers, eating might initially provide temporary relief, only for the pain to return later. This pain is normally intermittent, with periods of spontaneous healing and then recurrence, leading to a pattern of waxing and waning discomfort.
Comes and goes.
Vomiting, interestingly, isn't a notable feature unless there's significant stenosis or narrowing of the stomach outlet due to scarring from the ulcer, which physically blocks the passage of food.
Patients might experience weight alteration, either loss, particularly in those with gastric ulcers who might avoid eating due to pan, or sometimes even weight gain if eating offers temporary relief. Patients with gastric ulcers are often underweight, a condition that can even precede the ulcer's appearance.
And bleeding.
Bleeding is a common and serious complication, presenting either as chronic, subtle blood loss leading to microcytic anemia, iron deficiency anemia, which requires endoscopy for diagnosis, or acutely leading to overt hematemesis, vomiting frank blood or coffee grounds, and melena, black tarry stools due to digested blood.
On clinical examination, you might find some epigastric tenderness, a localized pain when the doctor presses on the upper abdomen. Otherwise, there's usually little to find on a physical exam unless the ulcer has led to a significant complication like gastric outlet obstruction, in which case you might detect a distended stomach or a succussion splash, a sloshing sound heard over the stomach.
For the investigation of a suspected peptic ulcer, gastroduodenoscopy is unequivocally the gold standard. This endoscopic procedure allows direct visualization of the stomach and duodenum.
Seeing is believing.
In the stomach, any abnormal lesion, whether it looks ulcerated or polypoid, absolutely must be biopsied. And for any lesion suspected of being a benign gastric ulcer, numerous biopsies, often as many as 10 carefully targeted ones from the edges and base, are taken to meticulously exclude malignancy as far as possible. This aggressive biopsy strategy is critical due to the cancer risk.
Additionally, during endoscopy, biopsies will typically be taken from the antrum to check for histological evidence of gastritis, and crucially, a CLO test, or rapid urese test, is performed on a biopsy to quickly detect the presence of H. pylori.
Checking for the bug.
The endoscopist will also perform specific maneuvers, such as the U maneuver, which involves retroflexing the scope to inspect areas that are otherwise hard to see, like the incisura angularis, the lesser curve, and the gastroesophageal junction, the meeting point of the stomach and esophagus. This area is particularly important given the increasing incidence of cancer at the GOJ.
If a patient has had prior gastric surgery and a stoma is present, such as after a gastroenterostomy or a Billroth II reconstruction, it's vital for the endoscopist to carefully navigate and enter both the afferent and efferent loops of the small intestine connected to the stomach. This is because almost all stomal ulcers are found close to the junction between the jejunal and gastric mucosa.
Got to check both limbs.
Careful attention is also given to the pylorus for any prepyloric or pyloric channel ulceration or any deformity that might indicate scarring or obstruction. And in the duodenum, the entire first part must be meticulously viewed and the endoscope advanced into the second part to ensure no lesions are missed.
Now let's talk about the treatment of peptic ulceration, because this area has seen a truly significant paradigm shift over the last few decades. The vast majority of uncomplicated ulcers, meaning those without severe bleeding or perforation, are now treated medically.
Surgery is much rarer now.
Surgical treatment for uncomplicated peptic ulceration has markedly decreased and is now very seldom performed. This represents a monumental change from historical practice.
Medical treatment, while it certainly includes vital lifestyle modifications like smoking cessation, which is crucial for healing and preventing recurrence, relies heavily on pharmacological measures. H2 receptor antagonists like cimetidine or famotidine revolutionized management when they were introduced, significantly reducing acid production.
Big step forward then.
But then proton pump inhibitors, or PPIs, came along, proving even more profoundly effective. They can essentially render patients eclohydric virtually no acid and are so powerful that they heal most benign ulcers within 2 weeks, providing rapid symptom relief. Both classes of drugs are generally very safe.
However, here's the key problem with all gastric antisecretory agents. Relapse is almost universal upon cessation of therapy, as they only manage symptoms, not the underlying cause in most cases.
The ulcer comes back.
This is where H. pylori eradication therapy truly shines and has become the definitive cure. It is now routinely given to all patients diagnosed with peptic ulceration. If H. pylori is the primary factor, which it is in the vast majority of non-NSI-related ulcers, then complete eradication of the bacterium will fundamentally cure the disease, preventing recurrence. Reinfection in adults is uncommon, making this a durable solution.
This makes H. pylori eradication therapy the absolute mainstay of treatment for peptic ulceration. It's not only incredibly effective, but also highly economical compared to prolonged, lifelong courses of antisecretory agents or the significant costs and risks associated with surgical intervention.
And much safer.
And crucially, it is considerably safer than surgery for the vast majority of patients.
There are, however, important exceptions where H. pylori eradication therapy might not be the primary or sole treatment. This includes NSAID-associated ulcers, where the fundamental treatment is to avoid the NSAIDs, or, if they must be continued, to co-prescribe potent antisecretory agents for ongoing protection.
Protecting the stomach lining.
Similarly, stromal ulceration, which often occurs due to anatomical changes after surgery, isn't effectively treated by H. pylori eradication alone and typically requires prolonged antisecretory agents. And patients with Zollinger-Ellison syndrome, a rare condition causing extreme acid overproduction due to a tumor, require long-term high-dose PPIs unless the tumor itself could be surgically managed.
What about those rare ulcers that, despite everything, still fail to heal? While the introduction of potent antisecretory agents and effective H. pylori treatments has revolutionized management, a small minority of ulcers stubbornly resist healing.
Refractory ones.
For all gastric ulcers, endoscopic reevaluation is absolutely mandatory. This is not just to confirm healing, but also to differentiate a truly refractory ulcer one that simply won't heal from a situation where the ulcer has actually healed, but the patient still experiences persistent symptoms.
The most common cause of failed ulcer healing is, perhaps unsurprisingly, persistent H. pylori infection, often due to resistance or incomplete treatment. If this is suspected, repeat biopsy should be taken at endoscopy to directly look for the bacterium, as breath tests can sometimes be false negatives soon after eradication therapy, and serum antibody titers may take up to 6 months or even longer to fall, not accurately reflecting current infection status.
So biopsies are key.
Failure of eradication is usually due to poor patient compliance with the full antibiotic regimen, or, as mentioned, bacterial resistance. In such cases, if resistance is suspected, a bacteriological culture of the H. pylori strain can be invaluable, as it allows for specific antibiotic susceptibility testing to guide further, more effective treatment attempts.
Other factors that need to be meticulously readdressed in cases of failed healing include ongoing NSAID ingestion, which can perpetuate the ulcer despite treatment. Zollinger-Ellison syndrome should always be suspected in H. pylori negative non-NSAID-associated ulcers, and serum gastrin levels should be measured to screen for this rare but important cause.
Got to check the gastrin.
Very rarely, a recently described autoimmune immunoglobulin G4-related phenomenon can cause resistant and recurrent gastric ulceration, highlighting the ongoing discovery of new causes for what might seem like common problems.
Moving now to operations for duodenal ulceration, it's incredibly important to frame this discussion historically, because there is now virtually no role for routine elective acid-reducing operations for duodenal ulcers.
Things have changed.
Historically, the primary goal of surgery was to either exclude acid from the duodenum, reduce acid secretion, or both. These complex procedures are only very occasionally needed today, almost exclusively in specific emergency situations where medical therapy has failed or complications require immediate intervention.
Let's consider some of the historical gastrectomy-based procedures. Operations like the Billroth I and Billroth the Apolia procedures were first performed in the late 19th century. Their primary aim was to surgically remove the gastric antrum, which, as we know, contains the gastrin-producing G cells, thereby reducing acid secretion.
Taking out the G cells.
The poliogastrectomy also had the added benefit of diverting gastric secretions away from the duodenal stump. While these operations have no elective role in modern management, the Billroth the Apolia procedure, which is generally considered safer in acute settings, is still occasionally used in specific emergencies for complex ulcer disease or severe bleeding, but it's a rare event now.
Another historical procedure, gastrointestinal, was initially developed as an operation specifically for duodenal ulcers. However, it was largely unsuccessful for that purpose due to a high incidence of stomal ulceration. New ulcers forming at the surgical connection caused by the jejunal mucosa being exposed to unbuffered acid.
Didn't work well for ulcers.
Today, however, gastroenteroscopy remains a commonly performed and very valuable operation, but its role has shifted dramatically. It's now typically performed to bypass malignant obstruction caused by tumors in the distal stomach, duodenum, or pancreas, where food cannot pass naturally. It's usually performed through the lesser sac with an isoperistaltic anastomosis, meaning the connection is made in the natural direction of peristalsis.
Then there are the vagotomy-based procedures, which were revolutionary in their time. The principle here is straightforward. By sectioning or cutting the vagus nerves, which are critically involved in stimulating gastric acid secretion, you can effectively reduce the stomach's maximal acid output by approximately 50%.
Cutting the nerve supply.
Truncal vagotomy, where the vagal nerves are cut high up at the lower esophagus, was a mainstay of duodenal ulcer treatment for many years, almost always combined with a gastric drainage procedure.
The reason drainage procedures were necessary after truncal vagotomy is because the vagus nerves also supply motor innervation to the stomach. Their denervation can cause gastric stasis, meaning the stomach muscles don't contract effectively to empty food.
So food just sits there?
Exactly. So drainage procedures like the Helicobacter pyloroplasty were common. This involves a simple longitudinal incision of the pyloric ring, which is then closed transversely, effectively widening the outlet. A gastrojejunostomy was an alternative drainage procedure for more severe cases of potential obstruction.
The more refined and less disruptive approach was the highly selective vagotomy. This procedure, also known as proximal gastric vagotomy, involves surgically denervating only the parietal cell mass of the stomach, the acid-producing area, while meticulously preserving the nerve fibers to the pylorus.
More targeted.
This preservation of pyloric function meant there was no longer a need for a separate drainage procedure, significantly reducing the postoperative complications associated with gastric stasis.
For gastric ulcers, the objective of surgery is fundamentally different than for duodenal ulcers. While duodenal ulcer surgery historically aimed to reduce acid exposure, for gastric ulcers, the primary objective is the excision of the ulcer itself to confidently exclude malignancy.
Back to the cancer risk.
As we discussed, any gastric ulcer must be treated as potentially cancerous until proven otherwise. The standard operation historically was the Billroth I, which removed a portion of the stomach containing the ulcer. But as with duodenal ulceration, such surgery for gastric ulcers is now performed only for complications like intractable bleeding or perforation, not for routine management of an uncomplicated ulcer.
Now, let's talk about the long-term realities that patients sometimes face after these historical operations, the sequelae of peptic ulcer surgery. Despite being performed less often today, approximately 30% of patients who underwent these older, more destructive operations experience some degree of dysfunction, with about 5% having truly intractable, debilitating symptoms.
Significant numbers still.
These sequelae primarily follow the more extensive procedures that are now seldom performed for benign disease. However, it's important to remember that many patients still live with the long-term effects of these past surgeries.
One potential complication is recurrent ulceration, which can occur after surgery, often presenting with symptoms of bleeding or perforation. A particularly devastating, though fortunately rare, complication is a gastrointestinal colic fistula. This occurs when an anastomotic ulcer, an ulcer at the surgical connection, penetrates directly into the transverse colon.
That sounds awful.
The symptoms of a gastrointestinal colic fistula are truly severe and often include profound post-meal diarrhea, foul-smelling breath, vomiting form feces. Yes, you heard that right, rapid and severe weight loss and dehydration. It can even be mistaken for malignancy due to the rapid and severe decline in the patient's health.
Oh my goodness.
The underlying mechanism is severe contamination of the duodenum with colonic bacteria, leading to a malabsorption syndrome.
Diagnosis can be tricky. While CT scans with oral contrast or a barium enema might show the fistula, it can still be missed. Endoscopy may not convincingly demonstrate the connection. Treatment is critical and stepwise. First, you must correct the severe dehydration and malnutrition that the patient experiences.
Stabilize first.
Only then can revisional surgery be performed to repair the fistula. It's a complex, high-stakes situation.
Small stomach syndrome is another sequela, characterized by early satiety, feeling full very quickly, often after just a few bites, even after highly selective vagotomy, where there's no anatomical disturbance. This symptom is attributed to the loss of receptive relaxation of the proximal stomach, meaning it can't expand as much to comfortably accommodate food.
Can't hold as much.
Fortunately, this condition tends to improve with time as the body adapts, and revisional surgery is usually unnecessary.
Bile vomiting can be a very distressing symptom, occurring after any vagotomy with drainage procedure or after a gastrectomy. Patients often vomit a mixture of food and bile, or just bile alone, typically after meals, often accompanied by abdominal pain and reflux symptoms.
Not pleasant at all.
Unfortunately, bile chelating agents, which aim to bind the bile, are usually ineffective. In intractable cases where symptoms are debilitating and persistent, revisional surgery may be indicated. A room-onward diversion, where a segment of duodenum is used to divert bile away from the stomach, is often the preferred choice after gastrectomy.
Then there are the notorious early and late dumping syndromes. These share the common feature of early, rapid gastric emptying food moving too quickly from the stomach into the small intestine, though their mechanisms differ. Many patients experience both.
Dumping.
Early dumping affects about 10% of patients post-gastrectomy or vagotomy with drainage, and a small percentage even after highly selective vagotomy due to the loss of receptive relaxation.
The mechanism of early dumping is the rapid emptying of a high osmotic load of food, meaning highly concentrated food, into the small bowel. This causes a rapid shift of fluid from the circulation into the gastrointestinal tract, a process that can actually be visibly demonstrated by a rise in packed cell volume in the blood.
Fluid shift.
Symptoms include both abdominal issues, like epigastric fullness, colic, and diarrhea, and systemic vasomotor symptoms, such as sweating, lightheadedness, rapid heart rate, faintness, and even profound prostration.
Management primarily involves careful dietary manipulation, recommending small, regular meals based on fat and protein, and crucially, avoiding high carbohydrate fluids. Fortunately, symptoms often improve significantly with time as the body adapts.
So diet helps.
For intractable cases where symptoms are severe and don't respond to diet, the somatostatin analog octreotide, given before meals, can be a useful pharmacological intervention. Revisional surgery is rarely needed for early dumping.
Late dumping, on the other hand, is distinctly due to reactive hypoglycemia, a sudden drop in blood sugar. The rapid entry of a carbohydrate load into the small bowel causes a very rapid and significant rise in plasma glucose, which in turn triggers an exaggerated surge in insulin production.
Overshoot of insulin.
This excess insulin then leads to secondary hypoglycemia, occurring typically 1 to 3 hours after the meal. This phenomenon can be easily demonstrated by serial blood glucose measurements. Treatment is essentially the same as for early dumping, focusing on dietary modification, and octreotide is very effective for managing this specific problem.
Post-vagotomy diarrhea can be a truly devastating symptom, proving intractable, unmanageable in approximately 5% of patients who undergo truncal vagotomy, with the exception of those who had the less invasive, highly selective vagotomy.
Just relentless diarrhea.
Yes. The exact cause is still uncertain, but it's thought to be related to extremely rapid gastric emptying, denervation of the upper gastrointestinal tract, and an exaggerated peptide response from the gut hormones. While management strategies are similar to those for early dumping, anti-diarrheal preparations may offer some relief. Unfortunately, octreotide is generally ineffective for this type of diarrhea, and the results of revisional surgery for this condition are highly unpredictable.
Malignant transformation is another significant long-term risk associated with some of these older surgical procedures. Partial gastrectomy or vagotomy with drainage are independent risk factors for the later development of gastric cancer.
Years later.
This increased risk is thought to be linked to chronic bile reflux gastritis and the development of intestinal metaplasia in the gastric remnant. There's typically a significant lag phase of at least 10 years, and often much longer, between the operation and the development of malignancy. The good news, however, is that highly selective vagotomy, which preserves the pylorus and avoids extensive gastric manipulation, is not associated with an increased long-term incidence of gastric cancer, highlighting the importance of surgical precision.
Nutritional consequences are also common, especially after gastrectomy, where patients often struggle to regain their original body weight due to reduced stomach capacity and altered digestion. Dietary advice primarily focuses on encouraging frequent small meals rather than large ones.
Smaller meals more often.
Iron deficiency anemia is a common occurrence after both gastrectomy and vagotomy with drainage procedures, primarily due to reduced iron absorption.
Vitamin B12 deficiency is an almost inevitable consequence after a total gastrectomy, as the entire source of intrinsic factor necessary for B12 absorption is removed. While megaloblastic anemia, a specific type of B12 deficiency anemia, may take years to manifest due to the body's B12 stores, routine B12 supplementation is absolutely essential for these patients.
Lifelong supplementation.
Rarely, it can also occur after a lesser gastrectomy due to reduced intrinsic factor production combined with bacterial colonization of the gastric remnant. Finally, bone disease, resembling postmenopausal osteoporosis but often more frequent and severe, is mainly seen in women after gastrectomy. Treatment involves dietary supplementation with calcium and vitamin D, along with regular exercise.
Lastly, gallstones can develop after truncal vagotomy. This specific procedure can denervate the biliary tree, affecting the nerves that control gallbladder function, which leads to biliary stasis or sluggish bile flow, and consequently an increased risk of gallstone formation.
Another side effect.
Symptomatic patients typically require cholecystectomy, the surgical removal of the gallbladder. However, it's important to note that this procedure can, unfortunately, sometimes induce or worsen other post-peptic ulcer surgery syndromes like bile vomiting or diarrhea, creating a complex clinical picture.
Now let's shift gears to Section 4. The acute crisis, the severe, often life-threatening complications of peptic ulcers. First up, perforated peptic ulcer, which is a true surgical emergency requiring immediate action.
Red alert situation.
Despite the widespread use of potent anti-secretory agents and H. pylori eradication therapy, its incidence remains largely unchanged, making it a persistent clinical challenge. It increasingly affects older patients and, interestingly, more females, and nonsteroidal anti-inflammatory drugs, NSAIDs, are now responsible for the majority of cases, highlighting the drug-induced nature of many modern perforations.
The classical presentation is instantly recognizable to any clinician. Sudden, excruciatingly severe, generalized abdominal pain. This pain is due to the irritant effect of highly acidic gastric contents spilling onto the peritoneum, the lining of the abdominal cavity.
Like acid burning inside.
Patients are typically in profound shock with a rapid heart rate, and within hours they develop bacterial peritonitis as the abdominal cavity becomes infected. The patient's condition rapidly deteriorates and fever develops later. On examination, the abdomen exhibits a characteristic board-like rigidity, so tense and stiff that there's no respiratory movement visible in the abdominal wall. This picture demands immediate operation.
However, this classical dramatic presentation is less common now, especially in elderly patients who may present less acutely, perhaps due to the blunting effects of anti-inflammatory drugs or a generally diminished physiological response. Board-like rigidity may be absent, requiring a much higher index of suspicion to make the diagnosis.
Need to be vigilant.
Sometimes the leak can be contained by surrounding structures, leading to more localized pain in the epigastrium or right iliac fossa as fluid tracks down the pericolic gutter. And in some cases, small perforations can even self-seal due to inflammation and adhesion of surrounding tissues, making diagnosis quite challenging and delaying definitive treatment.
For investigations, an erect chest radiograph is a quick initial test that will reveal free gas under the diaphragm in over 50% of cases, a telltale sign of a perforated hollow organ.
Air where it shouldn't be.
However, computed tomography, or CT imaging, is now the most commonly used diagnostic tool and is significantly more accurate, providing detailed images of the abdomen. While elevated, serum amylase should always be performed to help distinguish a perforated ulcer from acute pancreatitis, though CT is often diagnostic for both conditions.
Initial treatment priorities for a perforated ulcer are immediate resuscitation, stabilizing the patient's vital signs, and effective analgesia to manage the excruciating pain. It's crucial to understand that analgesia should not be withheld, as it actually helps clarify clinical signs by allowing the patient to relax and cooperate with examination.
Pain relief is key.
The primary definitive treatment is surgical, typically via laparotomy, an open abdominal incision, or increasingly, via laparoscopy, a minimally invasive approach. The most important component of the operation is a thorough peritoneal toilet, meticulously washing out and removing all gastric fluid and food debris from the abdominal cavity to prevent widespread infection.
For duodenal perforations, the hole is usually closed directly with transverse sutures. It's also very common to place an omental patch, a piece of fatty tissue from the omentum over the perforation, to enhance sealing and reinforce the repair. This is increasingly used as the sole repair strategy for simple perforations.
The omental patch.
Gastric ulcers, however, due to the critical malignancy risk, should ideally be excised, meaning the ulcerated tissue is cut out and then closed, to ensure histological examination can definitively exclude cancer. For massive perforations, particularly those causing significant tissue destruction, a more extensive procedure like a distal gastrectomy with Roux-en-Y reconstruction might be necessary. Minimally invasive laparoscopic repair is also possible with appropriate surgical expertise.
Post-operatively, the stomach should be kept empty with continuous nasogastric suction to allow the repair to heal. Gastric antisecretory agents should be started promptly to promote ulcer healing, and H. pylori eradication therapy is mandatory if the bacterium is present to prevent recurrence.
Standard post-op care.
A minority of patients with very small contained leaks and minimal contamination may be managed conservatively with intravenous fluids, nasogastric suction, and broad-spectrum antibiotics, but any sign of clinical deterioration prompts immediate surgical intervention. For long-term prevention of recurrence, especially if NSAID use must continue, lifelong PPIs are a reasonable and often necessary option.
Hematemesis and melena, or upper gastrointestinal hemorrhage bleeding from the upper digestive tract, remain a major medical problem with significant morbidity and mortality. Its incidence is over 100,000 per year in Western practice, and it sharply increases with age, often exacerbated by a strong association with NSAID use.
Still a big problem.
Despite advances in medical and endoscopic therapies, in-hospital mortality still ranges from 5–10% and alarmingly can rise to 33% if the bleeding begins in patients already hospitalized for other reasons, underscoring its severity.
The most common causes of upper GI bleeding are peptic ulcers, accounting for about 60% of cases. These are followed by gastric erosions, 26%, Mallory-Weiss tear, 4%, esophageal varices, 4%, tumors, 0.5%, and other rarer vascular lesions, 0.5%.
So mostly ulcers still.
The principles of management are immediate and simultaneous. Resuscitation is paramount, establishing intravenous access, often monitoring central venous pressure for severe cases, and placing a bladder catheter. Blood must be cross-matched and transfused if more than 30% of blood volume is lost. There's no strong evidence for routine intravenous PPI administration before endoscopy, as it doesn't improve outcomes in this acute setting.
Resuscitate first.
If bleeding is unrelenting, resuscitation, diagnosis, and treatment must all occur simultaneously. Any coagulopathy, a bleeding disorder, if present due to liver disease or anticoagulant medications, must be promptly corrected with fresh freezing plasma or clotting factors.
Endoscopy, performed by an experienced operator, is the key diagnostic and therapeutic tool. Its timing is critical. For mild bleeding, it can typically be done the morning after admission. But for severe active bleeding, it must be performed immediately, often within hours of presentation.
Timing battle.
Scoring systems like the Rockall score are invaluable. They're used both pre-endoscopy to stratify patients for safe early discharge or the need for intensive care, and post-endoscopy to predict the risk of rebleeding or death, guiding subsequent management.
For bleeding peptic ulcers, the epidemiology mirrors that of perforated ulcers. They tend to affect older patients and are frequently associated with NSAID use. Endoscopic diagnosis of the bleeding ulcer is usually possible.
Right.
Medical treatment alone has limited efficacy in stopping active bleeding, but once hemostasis is achieved, PPIs do prevent rebleeding. Interestingly, tranexamic acid, an antifibrinolytic agent that helps blood clot, may reduce overall mortality, though its role is still being refined.
Therapeutic endoscopy is highly effective, achieving hemostasis or stopping the bleeding in about 70% of cases. The best evidence supports a combination approach: injection of adrenaline, which causes local vasoconstriction, coupled with thermal coagulation using a heater probe or mechanical closure with endoscopic clips.
Clipping the vessel?
However, these methods are less effective for very large, actively spurting vessels. Angiography and embolization offer a valuable alternative to surgery in expert centers, particularly for cases with an unidentifiable bleeding source or rebleeding after initial endoscopic attempts. The stomach's rich collateral blood supply means there's a low risk of ischemia after embolization. However, if embolization fails, Rescue surgery carries a very poor outcome, making it a difficult decision.
Surgical treatment for upper GI bleeding is reserved for specific indications. These include persistent bleeding that cannot be controlled by endoscopic or angiographic means unless expert angiographic embolization is definitively an option. It's also indicated for a clearly visible or actively spurting vessel or a large adherent clot in the ulcer base that cannot be dislodged endoscopically.
When endoscopy isn't enough.
Early surgery is often advised for frail or elderly patients who might not tolerate prolonged conservative management, generally if more than 6 units of blood have been required for resuscitation.
The primary aim of surgery in an acute bleeding scenario is simply to stop the bleeding crew. It's a damage control approach to save the patient's life. For a bleeding duodenal ulcer, this typically involves full duodenal mobilization to expose the posterior wall, followed by a longitudinal opening of the duodenum, often as a pyloroplasty.
Getting access.
Hemostasis is then achieved by directly compressing the bleeding point and then meticulously underrunning the vessel with sutures to tie it off. The opening is then closed transversely. For very large destructive ulcers where primary closure is impossible, a more extensive procedure like a distal gastrectomy with Roux-en-Y reconstruction might be necessary. For gastric ulcers, the stomach is open, the bleeding vessel is underrun, and local excision or biopsy of the ulcer margins is performed. It's important to note that a full gastrectomy specifically for bleeding carries a very high perioperative mortality risk, so it's avoided if possible.
Postoperatively, pharmacological acid inhibition and H. pylori eradication therapy are crucial for preventing rebleeding and promoting long-term healing. For patients who require long-term NSAID use, careful management strategies, often including co-prescription of PPIs, are essential to minimize the risk of recurrent bleeding.
Stress ulceration occurs in critically ill patients, particularly those with major injury, severe illness, or who have undergone extensive surgery. Its incidence has fortunately been significantly reduced by prophylactic acid inhibition, such as with H2 antagonists or protective barrier agents like sucralfate, routinely given in the intensive care unit.
Prevention is key there.
Endoscopic treatment for stress ulcers is often ineffective due to their widespread nature. And if severe bleeding occurs, surgery may be needed, following the same principles as for chronic ulcers.
Gastric erosions, often superficial lesions caused by agents like NSAIDs, usually settle spontaneously with supportive care. However, if there's a specific lesion with a large vessel that is actively bleeding, it should be treated either endoscopically or, in rare cases, surgically.
A Mallory-Weiss tear is a longitudinal tear in the lining at the gastroesophageal junction, typically caused by strenuous vomiting or retching. It's a common cause of hematemesis and can be quite challenging to diagnose endoscopically due to its location, sometimes being missed.
Hard to spot sometimes.
While many stop bleeding spontaneously occasionally, it may require surgical intervention if bleeding persists and is severe.
A Dieulafoy lesion is a rare but critical cause of massive upper GI bleeding. It's essentially a gastric arterial venous malformation, an abnormally large artery that runs unusually close to the surface of the gastric lining, often without any other apparent abnormality.
Like a hidden time bomb.
It causes profuse, sometimes torrential, bleeding from what appears to be normal mucosa because it's often covered by just a thin layer of normal tissue and is invisible when not actively bleeding. If identified endoscopically, it can be treated with sclerosant injection or clips. Operative treatment involves precise local excision of the small offending artery.
Tumours, specifically gastric neoplasms, can certainly cause upper GI bleeding. This bleeding can be chronic, leading to iron deficiency anemia, or acute and unremitting, though typically not as torrential as a major arterial bleed. The treatment of these cases, unlike in benign ulcers, focuses on addressing the underlying tumor itself, whether through surgery, chemotherapy, or radiation.
Portal hypertension and portal gastropathy are other significant causes of upper GI bleeding, often seen in patients with severe liver disease. Bleeding gastric varices enlarged, fragile veins in the stomach due to high pressure in the portal system are very challenging to manage, much more so than esophageal varices, which are generally more amenable to endoscopic therapies like sclerotherapy or banding.
Gastric varices are tougher.
While gastric varices can sometimes be injected or banded endoscopically, it's often technically difficult. A Sengstaken-Blakemore tube, a specialized balloon tamponade device, can temporarily arrest massive hemorrhage. Intravenous octreotide or terlipressin are medications that can help reduce portal pressure. However, acute surgery on actively bleeding varices is largely avoided due to extremely high mortality rates and has been superseded by procedures like transjugulate intrahepatic portosystemic shunt, tip PS, which diverts blood flow away from the high-pressure varices.
Tip PSS is the go-to now.
Portal gastropathy refers to widespread, friable changes in the gastric mucosal lining due to portal hypertension, which also causes bleeding, and its treatment primarily involves managing the underlying portal hypertension.
Finally, in the context of unexplained hematemesis or melena, particularly if it's recurrent or severe, clinicians must consider an aortic enteric fistula. This is an abnormal connection that forms between the aorta, your body's main artery, and the gastrointestinal tract, usually the small bowel.
Aorta to gut connection.
Yes. The vast majority of patients with this condition have a pre-existing aortic graft, for example, from prior aneurysm repair, though it can occasionally occur with an untreated aortic aneurysm. The bleeding isn't always massive initially, sometimes presenting as intermittent herald bleeds. Diagnosis is confirmed by a CT scan with intravenous contrast. Treatment involves complex aortic aneurysm or graft excision and replacement, which carries a very high mortality rate due to the severity of the condition.
Now let's discuss gastric outlet obstruction, a mechanical blockage that prevents food from leaving the stomach, leading to significant symptoms and metabolic consequences. In adults, the two most common causes are gastric cancer and pyloric stenosis, secondary to chronic peptic ulceration.
With a decreasing incidence of peptic ulceration in Western countries, gastric outlet obstruction should now always be considered malignant until proven otherwise. This is a critical diagnostic shift.
Assume cancer first.
The metabolic consequences can also differ somewhat from benign pyloric stenosis because patients with gastric cancer often have relative hypochlorhydria, meaning they produce less stomach acid.
In cases of benign gastric outlet obstruction, usually due to long-standing peptic ulcer disease, there's typically a long history of recurrent ulcer symptoms. The vomitus is highly characteristic. It contains undigested food from meals eaten hours or even days ago, and crucially, it is totally lacking in bile, indicating that the obstruction is before the entry of bile from the duodenum.
That lack of bile is key.
Patients experience significant weight loss, appear unwell, and are often severely dehydrated. On physical examination, a visibly distended stomach may be apparent, and a succussion splash, a distinctive sloshing sound, can be heard when the patient is moved or palpated, indicating retained fluid in the stomach.
The metabolic effects of prolonged vomiting of gastric acid are profound, leading to hypochloremic alkalosis. When hydrochloric acid is lost through vomiting, the body tries to compensate. Initially, blood sodium and potassium levels might be relatively normal, but with progressive dehydration and continued vomiting, profound abnormalities arise.
Electrolytes go haywire.
The kidneys initially attempt to excrete bicarbonate in the urine to correct the alkalosis. However, as dehydration worsens, the kidneys prioritize retaining sodium and water, leading to paradoxical acidic urine, despite the systemic alkalosis. This also results in hypokalemia, or low potassium levels, as potassium and hydrogen ions are excreted to conserve sodium. The alkalosis also lowers the level of ionized calcium in the blood, which can manifest as tetany, causing muscle spasms and cramps. In contrast, in obstruction due to malignancy, these metabolic abnormalities are often less pronounced due to the relative hypochlorhydria that commonly accompanies gastric cancer. A subtle but important diagnostic clue.
Management of gastric outlet obstruction involves a dual critical approach. First, immediate correction of the metabolic abnormalities, and then addressing the mechanical obstruction itself. Patients are initially rehydrated aggressively with intravenous isotonic saline, often with potassium supplementation, to restore fluid and electrolyte balance, which allows the kidneys to begin correcting the acid-base imbalance.
Fix the fluids and electrolytes. The stomach must be completely emptied using a wide-bore nasogastric tube, sometimes requiring repeated orogastric lavage until it's clear of all retained food and fluid. Investigation involves endoscopy and contrast radiology like barium studies, which can pinpoint the obstruction. Critically, multiple biopsies taken from around the pylorus during endoscopy are absolutely essential to exclude malignancy.
Biopsy, biopsy, biopsy.
Treatment options vary. In early cases, especially those due to ulcer-related edema, the obstruction may settle conservatively as the swelling around the ulcer diminishes with acid suppression. For severe or persistent benign cases, surgical gastroenterostomy, creating a bypass around the obstruction, has been the traditional treatment. However, endoscopic balloon dilatation, where a balloon is inflated to widen the narrowed area, is increasingly useful in early cases and may require repetition.
Balloon dilation can work.
For unresectable malignancy-causing obstruction, duodenal stent insertion, placing a mesh tube to keep the passage open, may be considered as a palliative measure to allow patients to eat.
Now on to Section 5. The spectrum of gastric and duodenal neoplasms. We'll start with gastric polyps. Their main importance isn't usually their size, but rather that some types may actually represent early gastric cancer or have the potential to transform to cancer. Therefore, biopsy of any gastric polyp identified during endoscopy is absolutely essential to determine its nature.
Gotta know what it is.
There are several types. Metaplastic polyps are the most common. They're often associated with H. pylori infection and can actually regress or shrink after successful eradication of the bacterium. Inflammatory polyps are also quite common. Fundic gland polyps are interesting because they are associated both with long-term proton pump inhibitor, PPI use, and with familial adenomatous polyposis, FAP, a genetic syndrome.
FAP connection.
Crucially, neither metaplastic nor fundic gland polyps have proven malignant potential, meaning they are very unlikely to turn cancerous. However, true adenomas, a different type of polyp, do have malignant potential, similar to colonic adenomas, and therefore they should always be completely removed.
Let's talk about gastric cancer, a global health challenge that remains a major cause of mortality worldwide. Its prognosis is often poor due to late presentation, meaning it's typically discovered at an advanced stage when symptoms become apparent.
Often too late.
Cure rates in the West are typically low, around 5–10%, although they are significantly better in Japan due to different screening practices. It is eminently curable if diagnosed early, when the cancer is confined to the superficial layers, and the only curative treatment currently available is resectional surgery.
There are marked variations in the incidence of gastric cancer globally. For instance, Japan has an incidence of 70 cases per 100,000 per year, compared to a much lower rate of 15 in the UK. This dark difference highlights gastric cancer as largely an environmental disease influenced by diet, lifestyle, and infection.
Big regional differences.
Men are more frequently affected than women, and incidence generally increases with age.
In Western countries like the UK and US, there are significant shifting trends in gastric cancer incidence. The overall incidence is actually falling by about 1% per year, but this reduction exclusively affects cancers arising in the body and distal stomach. In stark contrast, there's been an alarming increase in the incidence of carcinoma in the proximal stomach, particularly at the gastroesophageal junction, GOJ.
That GOJ cancer rise is concerning.
Interestingly, distal and body cancers are more common in low socioeconomic groups, while the increasing incidence of proximal gastric cancer seems to affect higher socioeconomic groups. And importantly, proximal gastric cancer is not associated with H. pylori infection, unlike carcinoma of the body and distal stomach, suggesting different etiologies for these distinct types of gastric cancer.
The etiology, or causes, of gastric cancer are indeed multifactorial, a complex web of interacting factors. H. pylori plays a significant epidemiological role, as we've discussed, particularly for body and distal stomach cancers. However, there's currently insufficient evidence to support broad eradication programs for H. pylori in asymptomatic patients solely for cancer prevention, though this may change with future research.
Other predisposing conditions include pernicious anemia, a long-term autoimmune condition, and gastric atrophy, where the stomach lining thins, as well as gastric adenomatous polyps, as we just mentioned. Patients who have had prior peptic ulcer surgery, especially older drainage procedures like Bill Roth II gastrectomy, gastroenterostomy, or pyloroplasty, are at approximately 4 times the average risk of developing gastric cancer.
Post-surgery risk.
This increased risk is thought to be related to chronic bile reflux and the subsequent development of intestinal metaplasia in the gastric remnant.
Lifestyle and diet also play important roles. Cigarette smoking is a known risk factor, as is dust ingestion in certain occupational settings. Dietary factors are critical, as seen in the declining incidence among Japanese families who migrate to the USA and adopt a Western diet, or the specific pockets of high incidence in China.
Diet matters a lot.
Excessive salt intake, deficiency of antioxidants, and exposure to N-nitroso compounds, often found in processed and preserved foods, are also implicated. The specific etiology of proximal gastric cancer remains more of an enigma. It's not H. pylori associated, but has been linked to obesity and higher socioeconomic status. Finally, while not fully elucidated, genetic factors also play a significant role in a subset of gastric cancers.
Clinical features of gastric cancer vary significantly depending on the stage. Advanced gastric cancer usually presents with obvious and concerning symptoms. Early satiety, meaning feeling full very quickly after starting a meal, persistent bloating, abdominal distension, recurrent vomiting, profound and unexplained weight loss, and iron deficiency anemia from chronic subtle bleeding.
The classic warning signs.
If the tumor causes obstruction, patients might experience dysphagia, difficulty swallowing if the cancer is near the esophagus, or epigastric fullness. If the pylorus is involved, it leads to gastric outlet obstruction, though the metabolic alkalosis is often less pronounced than in benign obstruction due to the relative hypochlorhydria.
The real challenge, however, lies in early gastric cancer. This critical stage, where the cancer is confined to the superficial layers, has no specific features that reliably distinguish it from benign dyspepsia or common indigestion.
Hard to catch early.
This lack of clear warning signs necessitates a high index of suspicion from clinicians, especially in at-risk patients, and a low threshold for investigation. In the West, the proximal stomach, including the gastroesophageal junction, is now the most common site for gastric cancer, accounting for approximately 60% of all upper GI malignancies. This contrasts sharply with Japan, where distal cancer still predominates, highlighting different disease patterns globally.
Pathologically, when we examine gastric cancer under the microscope, the Lauren classification is most useful. It divides gastric cancer into two main forms based on its microscopic appearance: the intestinal type and the diffuse type.
Intestinal and diffuse.
The intestinal type resembles other tubular gastrointestinal tract carcinomas. It often forms polypoid tumors or ulcerated masses and is thought to probably arise from intestinal metaplasia, those pre-cancerous changes we discussed.
The diffuse type, on the other hand, is much more insidious. It infiltrates deeply into the stomach wall without forming obvious mass lesions, spreading widely within the submucosa. Critically, it has a worse prognosis than the intestinal type because it's often more aggressive and harder to detect and contain.
Gastric cancer is also broadly categorized macroscopically as early versus advanced gastric cancer. Early gastric cancer is, by definition, limited to the mucosa and submucosa, regardless of whether there's lymph node involvement or not. This is a critical distinction and is classified, particularly in Japan, into protruding, superficial, or excavated types.
Early means curable often.
Crucially, early gastric cancer is eminently curable, with remarkable 5-year survival rates around 90%. About 1/3 of gastric cancers are diagnosed at this early, curable stage in Japan, a testament to their screening programs. However, it's tragically uncommon in countries like the UK due to late referral for endoscopy, missing this window of opportunity.
Advanced gastric cancer, in contrast, involves the muscularis propria, meaning it has spread deeper into the muscle layers of the stomach wall. Its macroscopic appearances are classified by Borman into 4 types, with types 3 and 4, which are deeply infiltrative or widely ulcerative, commonly being incurable at diagnosis.
Molecular pathology is truly revolutionizing our understanding of gastric cancer, paving the way for more precise and targeted treatments. Next-generation sequencing, a powerful genetic analysis tool, has identified 4 distinct molecular subtypes: Epstein-Barr virus positive, microsatellite unstable, genomically stable, and chromosomal instability.
Tailoring the treatment.
The recognition of these molecular subgroups and their underlying genetic mutations, such as changes in genes like BRCA2, TP53, ARID1A, RHOA, and CDH1, along with perturbed signaling pathways like WNT, RQKs, receptor tyrosine kinases, and PI3KMAPK, is leading to an exciting era of targeted therapies. This includes the development of immunotherapies, which harness the body's own immune system to fight the cancer. However, it's important to remember that currently the primary treatment for gastric cancer still relies heavily on surgery, often combined with conventional chemotherapy or radiotherapy.
Staging is absolutely critical in gastric cancer, guiding treatment decisions and predicting prognosis. The UICC TNM 8th edition, which is the international standard, introduced important changes to reflect the latest evidence and improve outcome prediction. For tumors with their epicenter, the center point within 5 centimeters of the gastroesophageal junction and extending into the esophagus, they are now staged according to the esophageal cancer staging system.
Specific rules for GOJ tumors.
All other GOJ tumors and all other gastric cancers are staged by the revised gastric system, ensuring consistency.
When we talk about T4 disease, it signifies any tumor that has perforated the serosa, the outermost layer of the stomach, or has directly invaded adjacent structures. M1, or distant metastasis, is specifically defined as involvement of non-regional intra-abdominal lymph nodes, such as those behind the pancreas, in the mesentery, or around the aorta, as well as spread to the liver or the presence of peritoneal seedlings, which are small cancerous deposits scattered across the abdominal lining. Understanding these definitions is vital for accurate staging.
The patterns of spread for gastric cancer are quite distinct and crucial for understanding its prognosis and treatment. Generally, distant metastases are uncommon without accompanying lymph node involvement. The diffuse type of gastric cancer, which is more aggressive, tends to spread stealthily via submucosal and subserosal lymphatics. penetrating the stomach wall early.
Spreads differently.
Direct spread involves the tumor penetrating through the muscularis and serosa to directly invade adjacent organs, such as the pancreas, colon, or liver. Lymphatic spread, however, is a common and extensive route, occurring via permeation of cancer cells through lymphatic vessels and emboli to affected tiers of lymph nodes. This can be extensive, reaching even to supraclavicular nodes in the neck, sometimes presenting as a palpable mass known as Troisier's sign.
The Troisier's sign, yes.
Unlike in some other cancers like breast cancer, nodal involvement in gastric cancer does not necessarily imply systemic dissemination. It doesn't automatically mean the cancer is spread throughout the body. However, the prognosis depends heavily on the extent of regional lymph node involvement. Retrograde spread can occur if upper lymphatics are blocked. In Japan, they have developed highly advanced lymph node dissection techniques, meticulously clearing numbered lymph node stations based on their anatomical location and typical drainage patterns.
Blood-borne metastases, where cancer cells travel through the bloodstream, typically go to the liver first, then to the lung and bone. However, these are generally uncommon without prior nodal disease. Transperitoneal spread is very common once the tumor reaches the serosa, meaning it has broken through the outer stomach layer. This form of spread almost always indicates incurability.
Spread in the abdomen.
It manifests as tumor deposits anywhere in the peritoneal cavity, often accompanied by malignant ascites, which is fluid accumulation in the abdomen. This spread can lead to a palpable shelf felt during abdominal examination or spread to the ovaries, forming what are known as Krukenberg's tumors, or even to the umbilicus, forming Sister-Joseph's nodule. Laparoscopy, a keyhole surgery, and peritoneal cytology, examining abdominal fluid for cancer cells, are highly effective for detecting this form of spread.
Operability, deciding whether surgery is a viable path forward, hinges on avoiding fetal radical surgery in patients who already have incurable disease. This requires precise preoperative staging, which is why the value of advanced imaging techniques like CT and PT scans, along with diagnostic laparoscopic staging, a keyhole procedure to visually inspect the abdominal cavity, is absolutely invaluable.
Staging is everything.
Indicators of incurability include the presence of hematogenous metastases, meaning cancer has spread via the bloodstream to distant organs, distant peritoneal involvement, M1 nodal disease, meaning spread to non-regional lymph nodes, and clear fixation of the tumor to unresectable structures, making it impossible to remove surgically. However, it's important to note that the involvement of another organ per se doesn't necessarily mean incurability, provided that organ can also be excised en bloc with the primary tumor during surgery, achieving clear margins.
Treatment modalities for gastric cancer have truly evolved, becoming a multi-pronged fight against the disease. Neoadjuvant chemotherapy, meaning chemotherapy given before surgery, is now administered to most operable patients. This practice is supported by level 1 evidence, the highest level of clinical proof demonstrating improved survival rates.
Chemo first, then surgery.
The standard chemotherapy regimen has also been evolving. Historically, a platinum-based triplet combination called ECF, epirubicin, cisplatin, and 5-FU was standard. However, the landmark FLOT4 trial, which compared ECF to a newer regimen called Fluorosil, leucovorin, oxaliplatin, and docetaxel, where docetaxel replaced epirubicin, showed a significant survival advantage for patients receiving FLT, extending median survival from 35 months to a remarkable 50 months.
FOT is the new standard.
Despite these advances, challenges remain. Only a minority of patients truly benefit significantly from neoadjuvant chemotherapy, highlighting an urgent need for mechanisms to predict which patients will respond best. Furthermore, patient compliance with complex perioperative chemotherapy regimens can be an issue, impacting overall efficacy.
Total gastrectomy is a major surgical approach, often performed for gastric cancers high in the stomach or those involving extensive lymph node spread. The procedure involves a long upper midline incision, followed by the en bloc removal of the entire stomach, along with the entire greater and lesser omentum, these fatty aprons covering the abdominal organs.
Taking it all out.
A meticulous dissection of specific lymph node stations is also performed, including those around the subpyloric, hepatic, suprapyloric, left gastric artery, splenic artery, and splenic hilum areas. Crucially, the spleen and pancreas are generally preserved during this extensive lymphadenectomy. The duodenum is divided using a stapler, and the esophagus is divided with at least a 5-centimeter tumor-free margin, often confirmed by a frozen section biopsy during surgery.
After the stomach is removed, gastrointestinal continuity must be reestablished. This is typically achieved by creating a roux loop. This involves bringing a segment of the duodenum part of the small intestine up to connect to the esophagus.
The roux and
The alimentary limb, the part of the duodenum that carries food, must be at least 50 centimeters long to avoid bile reflux esophagitis, where bile can irritatingly flow back into the esophagus. The esophagojejunostomy, the connection between the esophagus and jejunum, is typically performed using a circular staple technique. Sometimes a jejunal pouch is created to function as a small reservoir, potentially offering long-term nutritional benefits to the patient.
Lymphadenectomy, the surgical removal of lymph nodes, is a crucial component of curative gastrectomy. Operations are classified as D1 or D2 based on the tiers of nodes removed. A D1 operation involves removal of only the perigastric nodes, those immediately surrounding the stomach. A D2 operation, which is the standard for curative intent in specialized centers, involves a more extensive clearance of lymph nodes located around the major arterial trunks supplying the stomach.
D2 is more extensive.
These specialist centers typically perform a radical total gastrectomy with D2 lymphadenectomy, often meticulously sparing station 10 lymph nodes, which are near the splenic hilum, to preserve the spleen.
Subtotal gastrectomy, where only a portion of the stomach is removed, is performed for tumors located in the distal stomach, preserving the proximal stomach. Reconstruction after a subtotal gastrectomy often involves a Roux loop as well, to minimize bile reflux into the remaining stomach remnant.
Palliative surgery, distinct from curative resection, is performed to alleviate significant symptoms like obstruction or bleeding when curative resection is not possible. Palliative gastrectomy involves a non-radical resection to remove the bulk of the tumor and reconstruct the gastrointestinal tract, aiming to improve quality of life.
Improving comfort.
If the tumor is completely unresectable, alternatives include a high gastroenterostomy, though this often has poor emptying in these patients, or a Roux loop with a wide anastomosis, which can still be challenging but may offer better palliation. Palliative intubation or stenting can also be used for inoperable tumors near the cardia, the upper part of the stomach, to relieve dysphagia.
Postoperative complications of gastrectomy are numerous and reflect the complexity of this major surgery. Anastomotic leaks, particularly from the esophagojejunostomy, the connection between the esophagus and jejunum, are a significant concern. These leaks, often involving saliva or ingested food, can sometimes be managed conservatively with drainage.
Leaks are a worry.
Duodenal stump leakage, where the end of the duodenum after its division leaks, is less common but usually due to distal obstruction.
The management of leaks and collections of fluid often involves radiologically or surgically placed drains. However, if there's biliary peritonitis bile leaking into the abdominal cavity, it requires urgent relaparotomy. A particularly catastrophic complication, thankfully rare but devastating, is hemorrhage occurring secondary to septic collections, especially after radical vascular dissection, as it can lead to bleeding from exposed major vessels, which is extremely difficult to manage.
Long-term complications and the overall outlook for patients after gastrectomy also show important regional differences. Functionally, there's often little difference in terms of quality of life or digestive issues between patients who undergo total versus subtotal gastrectomy. All patients need detailed nutritional advice, specifically emphasizing small, frequent meals throughout the day.
Adjusting eating habits.
Nutritional deficiencies are common, including vitamin B12 deficiency, which absolutely requires routine lifelong replacement therapy, iron deficiency anemia, and bone disease due to altered absorption and metabolism.
The outlook after surgical treatment for gastric cancer varies considerably between the West and Japan. In Japan, approximately 75% of patients undergo a curative resection, meaning the entire tumor and involved lymph nodes are removed with clear margins, leading to impressive overall 5-year survival rates of 50–70%.
Much better survival there.
In contrast, in Western countries, only about 25–50% of patients undergo truly curative operations, resulting in lower 5-year survival rates of approximately 25–30%. These significant differences are primarily attributed to variations in staging practices and surgical standards, a phenomenon often referred to as stage migration, meaning cancers are diagnosed at earlier, more treatable stages in Japan due to screening, and their surgical techniques for lymph node dissection are more extensive.
Other treatment modalities for gastric cancer, beyond surgery and neoadjuvant chemotherapy, primarily focus on palliative care for advanced disease. Palliative radiotherapy, while controversial due to the sensitivity of surrounding tissues, can play a limited but important role in managing painful bony metastases or local symptoms like bleeding or obstruction.
Palliative chemotherapy is a mainstay for advanced gastric cancer that cannot be surgically cured. Several regimens are used, often including platinum-containing triplet combinations or the FLOT regimen. Second-line chemotherapy with agents like docetaxel is also used when initial treatments fail. These treatments aim to control disease progression, alleviate symptoms, and extend life, but typically not to cure.
Newer biological agents represent an exciting frontier. Trastuzumab, also known as Herceptin, is a monoclonal antibody approved for the treatment of HER2 positive gastric cancer, a specific molecular subtype.
Targeting HAR2.
While it offers a small but statistically significant survival advantage in these patients, its high cost needs to be weighed against its benefits. This highlights the growing importance of molecular testing to personalize cancer treatment.
The pattern of relapse following surgical treatment for gastric cancer most commonly occurs in the gastric bed itself, the area where the stomach once was. This often indicates inadequate primary tumor extirpation, meaning some cancer cells were left behind.
Cancer coming back locally.
Widespread nodal intraperitoneal spread, distant nodal metastases, and liver metastases are also very common sites of relapse. Lung and bone metastases usually occur after liver metastases are established, indicating widespread disease.
Moving beyond adenocarcinoma, let's explore gastrointestinal stromal tumors, or GISTs, a truly distinct entity. These are mesenchymal origin tumors, meaning they arise from connective tissue, not epithelial lining. Approximately 50% of GISTs are found in the stomach.
Not your typical stomach cancer.
A groundbreaking discovery revealed that these tumors are almost universally associated with a specific mutation in the tyrosine kinase key-kit oncogene, a gene involved in cell growth.
This genetic link is absolutely crucial because it explains why these tumors are remarkably sensitive to a targeted therapy. The tyrosine kinase antagonist imatinib, a drug that specifically blocks the activity of this mutated c-kit protein. Imatinib leads to an impressive 80% objective response rate in advanced GENTs, causing tumors to shrink significantly.
Targeted therapy works well.
Tumors with specific mutations in exon 11 of the KIT gene are particularly sensitive to imatinib. While the biological behavior of GISTs can be unpredictable, their size and mitotic index, how fast the cells are dividing, are the best predictors of their metastatic potential. The most common sites of spread are the peritoneum and the liver, but critically, lymph node spread is extremely rare for GISTs, a key distinguishing feature from adenocarcinoma.
GISTs are less common than gastric cancer, constituting only 1–3% of all gastrointestinal neoplasms. Many small GISTs are incidental findings during an endoscopy performed for other reasons. Clinically obvious tumors might present with ulceration, leading to bleeding and anemia.
Can present like an ulcer.
Because the overlying gastric mucosa is often normal, a standard endoscopic biopsy taken from the surface can be uninformative unless the tumor has ulcerated through. In these cases, a targeted biopsy guided by endoscopic ultrasonography, where an ultrasound probe is passed down the endoscope to visualize deeper layers, is much more helpful. Larger GISTs can present with nonspecific gastric symptoms like discomfort or fullness, often initially mistaken for gastric cancer.
The management of GISTs is primarily guided by their size. Tumors greater than 5 centimeters are generally considered to have a significant metastatic potential. For easily resectable tumors, surgery is the primary treatment. Smaller tumors can often be removed via a simple wedge excision of the stomach.
Simpler surgery often.
For larger tumors that might require complex multivisceral resection, meaning removal of parts of adjacent organs, neoadjuvant imatinib, given for 3 to 6 months before surgery, can be invaluable. It often significantly reduces the tumor size and vascularity, making the subsequent surgery easier and safer.
Shrinking at first.
Adjuvant imatinib therapy, given after surgical resection for tumors with high malignant potential, is also common and is often continued indefinitely, dramatically improving long-term outcomes. The prognosis for advanced metastatic GISTs has been dramatically improved with the advent of imatinib chemotherapy, but surgical resection of metastases, where feasible, also plays an important role.
Next, let's explore gastric lymphoma, often with a fascinating MALT connection. Unlike gastric carcinoma, the incidence of gastric lymphoma appears to be increasing. It's most commonly diagnosed in individuals in their 6th decade of life. The clinical presentation is similar to gastric cancer, with symptoms like abdominal pain or weight loss, but acute presentations such as massive hematemesis, perforation, or acute obstruction are uncommon, in contrast to aggressive carcinomas.
Different presentation usually.
Primary gastric lymphoma accounts for about 5% of all gastric neoplasms.
It's important for pathologists and clinicians to distinguish primary gastric lymphoma, where the lymphoma originates in the stomach, from the more common involvement of the stomach as part of a diffuse systemic lymphoma that is spread to the stomach. Primary gastric lymphomas are B-cell derived, meaning they originate from a specific type of white blood cell and arise from mucosa-associated lymphoid tissue, or MALT, hence the term MALT lymphoma.
Multiple lymphoma.
They often remain localized in the stomach for prolonged periods before involving regional lymph nodes or spreading elsewhere in the body. Early-stage disease may present as diffuse mucosal thickening or isolated ulceration. Diagnosis is made by endoscopic biopsy, as the endoscopic features alone are not specific enough to differentiate it from other gastric lesions.
Staging is absolutely necessary to distinguish primary localized gastric lymphoma from a generalized systemic process. This typically involves a comprehensive workup, including CT scans of the chest and abdomen to look for spread, and often a bone marrow aspirate biopsy to check for involvement of the bone marrow.
Treatment for gastric lymphoma is somewhat controversial and depends heavily on the stage. For very localized disease, surgery alone has been considered appropriate by some, while chemotherapy is the mainstay for systemic disease.
Surgery versus chemo.
What's truly remarkable, and a testament to the H. pylori story, is that lymphocytes, usually found only minimally in normal gastric mucosa, are found in abundance in association with Helicobacter infection in the gastric mucosa. Crucially, early-stage gastric lymphomas, particularly low-grade MALT lymphomas, may dramatically regress and even completely disappear with successful Helicobacter infection treatment, highlighting a direct pathogenic link.
Wow, treating the bug treats the lymphoma.
In some cases, yes, particularly early MALT lymphomas. It's quite amazing.
More diffuse lymphomas involving the stomach are treated with systemic chemotherapy, sometimes resulting in dramatic and rapid tumor regression. However, a significant clinical caveat is that complications like bleeding and perforation can sometimes follow chemotherapy, precisely because of this rapid tumor regression and necrosis, the dying off of tumor tissue.
Tumor lysis complications.
In these situations, emergency gastrectomy may be required to manage the complication.
Finally, let's explore duodenal tumors beyond just ulcers. Benign duodenal tumors are relatively uncommon. One notable type is villous adenomas, which occur principally in the periampullary region, that area around the ampulla of Vater, where the bile and pancreatic ducts drain into the duodenum.
Near the amla.
These adenomas are rare, but are often found in patients with familial adenomatous polyposis, or FAP, a genetic syndrome. Similar to colonic adenomas, they have significant malignant potential and should therefore be locally excised with clear margins to prevent cancer development.
Duodenal adenocarcinoma is the most common site for adenocarcinoma of the small intestine, despite the small intestine being much longer than the stomach or colon. Most duodenal adenocarcinomas originate in that same periampullary region, commonly arising from pre-existing villous adenomas.
Cancer arising from the adenome.
Patients typically present with symptoms like anemia due to chronic ulceration and bleeding, or increasingly with obstruction as the tumor grows and blocks the duodenal lumen. If the ampulla of Vater is involved, it leads to obstructive jaundice, where bile flow is blocked and the patient turns yellow.
Pathologically, it is an adenocarcinoma, and unfortunately, metastases commonly occur to regional lymph nodes and the liver. At presentation, approximately 70% of patients have resectable disease, meaning the tumor can be surgically removed. However, despite this resectability, the 5-year survival rate is only about 20%, highlighting its aggressive nature.
Poor survival, even if resectable.
Poor prognostic features include regional lymph node metastases, transmural involvement, meaning the tumor has grown through the entire duodenal wall, and perineural invasion, where cancer cells spread along nerves. Curative surgical treatment for duodenal adenocarcinoma, particularly those in the periampullary region, typically involves a complex procedure called a pancreatic choduodenectomy, commonly known as Whipple's procedure, which involves removing part of the pancreas, duodenum, gallbladder, and bile duct.
The Whipple's procedure. Big operation.
It's important to reiterate the strong link with FAP patients who, due to an APC gene mutation, are highly predisposed to developing periampullary cancer. In fact, this type of cancer is a common cause of death in FAP patients, even after they've undergone a colectomy to remove their large intestine to prevent colon cancer. Therefore, regular endoscopic screening of the duodenum is strongly advisable for these patients.
Screening is vital for FAP.
Other types of malignancies can also occur in the duodenum, including GESTs, which we discussed, and various neuroendocrine tumors.
Neuroendocrine tumors also frequently occur in the duodenum. The duodenal loop is a common site for primary gastrinoma, a specific type of neuroendocrine tumor that produces excessive amounts of the hormone gastrin, leading to a condition called Zollinger-Ellison syndrome.
ZE syndrome tumors.
Non-functioning neuroendocrine tumors, or carcinoid tumors, can also occur in the duodenum, but they are less common here compared to their more frequent occurrence in the alveolum, a lower part of the small intestine.
Zollinger-Ellison syndrome, as mentioned, is caused by a gastrin-producing endocrine tumor called a gastrinoma. These tumors are often found in the duodenal, but can also originate in the head of the pancreas. This uncontrolled overproduction of gastrin leads to severe, persistent peptic ulceration.
Massive acid production.
Before the widespread availability of potent PPIs, Zollinger-Ellison syndrome was known for causing fulminant, severe ulceration that was tragically unresponsive to conventional surgery, often requiring a total gastrectomy to control the acid. Thankfully, PPIs now make the syndrome controllable for most patients, though it can be less easily recognized in the era of widespread acid suppression.
Gastrinomas can occur sporadically, meaning spontaneously, or they can be associated with an autosomal dominant genetic syndrome called multiple endocrine neoplasia, MNN type I, where patients almost invariably have a parathyroid adenoma as well.
MN type I link.
Most gastrinomas are found within a specific anatomical area known as the gastrinoma triangle. This triangle is defined by the junction of the cystic duct and common bile duct superiorly, the junction of the second and third parts of the duodenum inferiorly, and the junction of the neck and body of the pancreas medially, essentially centered around the superior mesenteric artery. Many of these tumors are small and located within the duodenal wall itself, thought to arise from G cells within Brunner's glands, which are special glands in the duodenal lining. Therefore, meticulous inspection of the duodenal wall, both endoscopically and during surgery, is crucial, as often only a small nodule is detectable.
Even malignant sporadic gastrinomas, which is spread, can sometimes have a remarkably indolent course, meaning they progress very slowly over many years. Palliative resection of liver metastases where feasible can be beneficial, and even liver transplantation has been practiced in select cases.
It can be slow growing sometimes.
However, tumors found to the left of the superior mesenteric artery generally have a worse prognosis. In MN type I patients, the gastrinomas are often multiple and widely disseminated, making them incurable in most cases. However, surgical treatment of obvious tumors and any lymphatic metastases can still provide good palliation, alleviating symptoms, and improving quality of life for a significant period.
Finally, let's consider duodenal obstruction, a blockage within the duodenum. In adults, this is usually due to malignancy, with pancreatic cancer being the most common cause, as the head of the pancreas wraps around the duodenum.
Pancreatic cancer causing blockage.
Treatment for malignant duodenal obstruction is often a gastroenterostomy, creating a bypass between the stomach and a lower part of the small intestine. However, duodenal stenting, where a stent is placed endoscopically to keep the lumen open, is increasingly used as a less invasive palliative option. Gastric drainage may also be needed for surgical biliary bypass when pancreatic cancer is causing both biliary and duodenal obstruction.
Other malignancies that can cause duodenal obstruction include metastases from colorectal cancer and gastric cancer, while primary duodenal cancer, as we discussed, is less common as an obstructive cause. Annular pancreas is a rare congenital cause, where a ring of pancreatic tissue encircles the duodenum, often presenting after pancreatitis and sometimes mistaken for malignancy.
Annular pancreas, right.
Lastly, arteriomesenteric compression is an ill-defined condition where the fourth part of the duodenum is compressed between the superior mesenteric artery and the vertebral column. If severe and causing significant weight loss, a duodenogenostomy, a surgical bypass, may be performed.
Let's quickly touch on a few other gastric conditions that, while less common, present unique clinical challenges. Acute gastric dilatation is an alarming condition characterized by an enormous, sometimes life-threatening dilation of the stomach.
Stomach blows up like a balloon.
This typically occurs in patients with pre-existing pylori-duodenal disorders that cause obstruction, or sometimes after major abdominal surgery. It can lead to profound dehydration and electrolyte disturbances, and crucially, there's a significant risk of sudden, massive vomiting with aspiration, where stomach contents enter the lungs. Treatment involves immediate large-bore nasogastric suction to decompress the stomach, aggressive fluid replacement, and addressing the underlying condition causing the dilatation.
Bezoars are fascinating, though unusual, foreign bodies found in the gastrointestinal tract. The most striking type is a trichobezoar, which is literally a hairball.
Hairballs, really?
Yes, really. These are almost exclusively found in young psychiatric patients who compulsively ingest their own hair. Because hair is indigestible, it accumulates in the stomach, forming a dense mass. Complications can be severe, including ulceration of the stomach lining, gastrointestinal bleeding, perforation of the stomach wall, or even obstruction. Diagnosis is usually easily made at endoscopy as the hair mass is visible. However, Removal may require open surgical treatment as they are often too large or firm for endoscopic extraction.
Phytobezoars, on the other hand, are made of vegetable matter, often from high-fiber foods, and are found primarily in patients with gastric stasis, meaning their stomach doesn't empty properly, usually after certain gastric surgeries.
Undigested plant matter.
For other ingested foreign bodies in the stomach, the approach is often expectant. Many objects, especially metallic ones, are visible on plain radiographs. Endoscopic removal is preferred if the object poses an immediate risk or is unlikely to pass. However, it's surprising how many objects can be left to pass normally, even seemingly sharp items like needles, which seldom cause harm once they leave the stomach.
Amazing what can pass through.
Objects that successfully navigate the pylorus and leave the stomach usually pass spontaneously through the rest of the bowel without issue. Attempted removal at laparotomy open surgery can actually be surprisingly difficult. For adults, given the common psychiatric link to foreign body ingestion, initial treatment should be expectant and conservative, reserving intervention only for the development of symptoms or clear failure of the object to progress.
Lastly, let's discuss volvulus of the stomach, a rare but acute condition where the stomach twists around its axis, usually between the cardia and the pylorus. Organoaxial volvulus, where the stomach rotates horizontally, is more common than mesenteroaxial, a vertical rotation.
The stomach twists on itself.
This condition is usually associated with a large diaphragmatic defect around the esophagus, such as a periesophageal herniation, where a portion of the stomach slips up into the chest. In these cases, the transverse colon may also move upwards, effectively carrying the stomach with it and predisposing it to twisting.
Clinically, stomach volvulus can be chronic, presenting with vague symptoms like difficulty eating or post-meal fullness. However, an acute presentation, where the twist causes immediate obstruction and potentially ischemia, lack of blood flow, can be a surgical emergency.
Acute volvulus is serious.
Diagnosis can be challenging with endoscopy, as the altered anatomy is hard to identify. Contrast radiography, such as a barium swallow, is superior for visualizing the twisted anatomy. If symptomatic, surgical treatment is required, and it's increasingly performed via a laparoscopic or keyhole approach. The surgery involves reducing the hernia sac contents back into the abdomen, closing the diaphragmatic defect, often with mesh reinforcement, carefully separating the stomach from the transverse colon if they are adherent, and finally, performing an anterior gastropexy, which is a procedure to fix the stomach to the anterior abdominal wall to prevent future twisting.
Wow, we have truly navigated the intricate world of the stomach and duodenum. From their astonishing microscopic cellular functions and the delicate balance of their hormonal and nervous controls, to the pervasive, Nobel-winning influence of H. pylori, the nuances of various forms of gastritis, and the complex challenges of peptic ulcer disease and its complications.
It's been quite a journey.
We've also explored the full, often stark spectrum of benign and malignant tumors, including the revolutionary impact of targeted therapies like imatinib for GCYSTs. This has been a comprehensive journey, dissecting every critical detail.
And this level of detailed, interconnected understanding is precisely how professionals truly master the field. It allows for a profound appreciation of how these systems and diseases interact, enabling truly informed decisions in diagnosis, treatment, and long-term patient care. It's about seeing the whole dynamic picture, not just individual symptoms.
Absolutely. You start to see all the connections.
Having immersed ourselves in this intricate world, it's clear that the health of the stomach and duodenum is profoundly linked not just to internal mechanisms, but also to a complex interplay of external factors: our diet, the medications we take, and even broader socioeconomic conditions. So beyond the cutting-edge medical interventions and surgical solutions we've discussed, what broader societal or lifestyle shifts do you think could have the most profound and widespread impact on the future health and resilience of these vital organs? It's a question that invites us to look beyond the individual, considering how our collective choices shape digestive health for generations to come.